Okay, so without further ado, I'll hand over to Dr. Nicki Law. Thank you.
Thanks, Ruth. Can everyone hear me okay?
Yeah.
Yeah.
So someone was just asking earlier about cameras and leaving them on or turning them off. So it's quite nice to see faces. So I'm quite happy if the cameras are on. If our connection's not very good, we might have to just turn them off.
Yeah, my camera's not working.
No, that's fine. That's fine. And can everybody put their microphones on mute, just so we don't hear lots of background noise? Obviously, you can put them back on if you want to say something. Is that okay? Right, I'm going to share my screen with you so you can see the presentation. If there's any problems, just put your hand up or ask a question. Well, I hopefully am. I've just tried it once. Can you see that?
Yes, we can see that here.
Yeah. If anyone can't see it, put their hand up and we can deal with that. Can everybody see it now?
Yeah. Yes.
Okay. The way it's set up on my computer, I can't actually see your faces anyway, so I don't mind if your cameras are on or off because I can't see you. So yeah, we'll start. So just to tell you about me, I've been a GP for 19 years. I've been in Lincoln nearly 2.5. I work at Abbey Medical Practice. I was in York for a long time before I moved to Lincoln, and I've always been interested in dermatology. So I did the Cardiff diploma in dermatology in, I think, 2009, 2010, which was really good. And then I did work in a hospital clinic for about 8 months, I'd say, just one afternoon a week. And then that kind of ended, and I just do dermatology in general practice, which I think is more interesting than dermatology in hospitals. And so I'm just going to share some of that with you today, and hopefully there'll be some useful things there. So this is what I've put as the learning outcomes for today. So I hope these are all things that you want to learn: how to assess a patient with a skin problem, how to describe their problem using the right sort of dermatological terms, how to recognise some common things that we see in general practice, and how to pick what treatments you're going to use for that appropriately. I hope so. I hope that's good. So the plan is to have kind of 3 sessions. There are 3 different bits to it, which I hope will all be about 45 minutes each, and we'll have breaks in between those. I've made handouts for each of the presentations, so you don't need to write lots of things down, because hopefully everything I say and the things that I wish I'd said but forgot will all be in the handout. It would be good if it can be interactive. I don't know whether we'll manage that over Teams, but if you do feel happy to answer some questions or speak up, that would be brilliant. And then I added in relax at the bottom, because I know sometimes you don't want to talk, and I don't need to spend the morning panicking that I'm going to pick on you because I could pick out names from the list. I won't do that. So if people who feel happy to share things would do, that would be great. But everyone else, don't panic that you're going to be picked on, because I won't. So just a little bit about dermatology in primary care. There was this King's Fund report from 2015, which said that they just looked at dermatology in the population, and that every year 54% of the population have some kind of skin problem that would be worth seeing a doctor or a nurse or a pharmacist about, which is huge. And they say 24% of the population visit their GP at some point during the year with a dermatology problem. So it's a massive thing. They say it accounts for 20 to 25% of a GP workload. And I've thought about this, and I'm not sure that I feel that it's quite that high, but that's what they found when they looked at the figures overall. And I know we're not teaching doctors today, but for most doctors in their undergraduate training, the average amount of time that they get taught anything about dermatology is 2 weeks. So for some people, it's as little as 1 or 2 days, and perhaps some people get a month or so, but it's very, very small amount of training when you look at how much of our workload deals with dermatology problems. So I don't know how much training any of you have had. What we're doing today is all kind of really basic stuff. So if you've already done some of the basics, you might have covered some of that, but hopefully it will be useful. There's only 650, this is in 2015, 650 consultants in the country. So most of the work of dermatology is going on in primary care. They said there were 13 million GP consultations for skin problems every year, and only about 5% of those get referred. So we're doing the work, really. So we'll just start with talking about how we assess a patient with a skin problem. And I think when I've talked to some of my friends and colleagues, they have a little bit of panic. They say when someone comes and says, oh, I've got a rash, and they think, I don't think I'm going to know what this is. But don't panic, it's just the same as any other problem, really. So we would start with the history. And I'll ask you at this point, if anyone's happy to speak, what things would you want to ask in the history? So if someone came and said, I've got a problem with my skin, or I've got a rash, or I've got something I'd like to take a look at, what kind of questions do you want to ask them about that?
When did it start?
When did it start? Good.
Where is it?
Where is it? Perfect.
How long they've had it for?
Yeah.
And have they had it before?
Yeah, good.
Does it weep?
Does it weep? Yeah.
Does it itch?
Sorry, what was that?
Does it itch?
Does it itch? Yeah, so kind of all symptoms associated with the rash that they've got.
Any new medications?
Any new medications? Yep, that's good.
Someone's put in the chat box, any allergies?
Any allergies? Yeah. And I think in terms of medication, any new medications, but also important to know all about what medication they're on at that time as well. Any more?
Have you taken anything to relieve it?
Yeah, have they tried anything? So any tablets, any creams, anything like that? Good. Sorry, did someone say something else?
Are they well in the chat box?
Yeah, are they well? That's important, isn't it? Is the rash part of a bigger thing, not just a skin problem? Yeah. Any others?
Do they feel feverish?
Sorry, what was that?
Do they feel feverish?
Do they feel feverish, or have they checked their temperature? And then we might be thinking about some systemic thing going on. Yeah, good.
Probably not at the moment, but any recent travel?
Yeah, yeah. Yeah, and we can pick things up from abroad or all kinds of things. So yeah. Any more? Or
Another one.
My list. I mean, you've pretty much covered everything on here. So I guess I would ask things that make it worse, things that make it better, but we sort of covered that a bit in what they've tried and so on. Stressful things that are going on at all. I'm thinking of more moles and things like that. Any sort of what sun exposure they've had and whether they've used sunbeds and things. And then probably the other things that we didn't mention were a family history of any skin disease and a social history. And we'll talk a little bit more when we look at some of the conditions, but for some skin conditions, kind of what job they do, what hobbies they enjoy can be quite relevant. So moving on. So once you've taken a history from someone, then you're advised to examine the patient fully. And if you read a dermatology textbook, it'll say strip out the patient off and have a full look at their skin. I find that quite tricky, and I tend to, if it's something where you need to look everywhere, I tend to kind of take their top off, have a look at the top half, and then have a look at the bottom half. But for a lot of things, we don't need to see the whole skin. They'll tell us where they've got it, and we just need to see the relevant place. So start with inspecting, having a look at the skin, and then move on to palpate. So we should really feel rashes if people have got them and decide what they feel like. It's a bit tricky at the moment with all the PPE and wearing gloves. Can't really do that. So we can ask the patient what it feels like if they touch it. We can't do that ourselves. Systematic check is an additional thing that you should do, you should always check the nails, scalp and mucous membranes. I'm not brilliant at always remembering to do that, but that's what we should be doing. And then describe what you see. So that all seems quite straightforward, and I think that's all okay, but it's when you get to the describe bit that it gets difficult, because a lot of people just don't have the words they need to describe what they see. So I've just got a little thing for you to have a go at. So just have a think, either write down or just think in your head. How would you describe this rash if this was a patient you saw and you wanted to write something in the notes, or you wanted to refer to somebody or phone somebody for advice? How would you describe what you see there? I'll just give you a minute to have a little think about what you would write, and then if anyone's happy to share, that would be great. Okay, so is anyone happy to say what they might say about this rash if they saw this person's legs? Did you find it difficult? Oh, sorry. That just moved on. Fine. I think maybe you don't want to share because it was a difficult thing to do. What I'm going to talk about now is words that you can use to describe skin problems and show pictures of what they mean. Did everybody get the email with the handouts on? So maybe you've printed off those two sheets we talked about.
No.
Yeah.
Have people got those?
Yeah.
I didn't.
Yeah.
Yeah.
Ruth, are you able to maybe email it to people that don't have it at some point? Because it would be very useful to use.
Yes. Yeah. Everyone should have it in the email with the link. Has anyone not got it at all? Or it's just sitting on their computer somewhere?
I didn't get it because I didn't get the link until just now.
Is that Maria?
It is, yeah. If you just send it, that'd be great.
There, you're not on our list of attendees, but I will send you an email after the session with those documents.
Yeah, that's fine. Thank you.
Thank you.
Okay, so we'll carry on. So thinking about terms that you could use to describe rashes, these are the kind of sections and ways that you can think about what words you could use. So we'll just go through those different sections. So first of all, the site, which part of the body is affected, and we'd ask that in the history, but we can just have a look. And that's probably an easy bit to describe, whether it's the legs, the arms, the scalp, all over or whatever. And then the number, so how many things they've got. If they've come about a skin lesion rather than a rash, have they just got one of those or have they got multiple? Distribution. We can look at whether it, and these terms are kind of useful for describing, but they also help us in terms of making a diagnosis. So if we think when we see patients about how we describe it, it does help with us thinking about what's going on. And partly because I think more when we get to this point, really, how is the rash distributed? If it's symmetrical, kind of more likely to be a skin disease that comes from inside us. So something like eczema, psoriasis, rather than if it's asymmetrical, like this person, it's just affecting one leg. You start to think, well, what's caused that on one leg? Is it something they've come into contact with? Is it an infection or something that's from outside the body that's just affected that area? So it does help us. And I think when we're taking the history and when we're examining people, we're looking for those clues that help us make a diagnosis. Unilateral is another word that we could use, affecting just one side of the body. And I think the difference, because asymmetrical and unilateral, what would a difference be? I think the unilateral bit is you can kind of see that line down the middle of the body and the rash doesn't cross over that. Localized, so just affecting a small area of the body, or generalized when it's widespread over the body. And then some rashes can be in sun exposed areas. If it's sun exposed, you get kind of a bit of a shadow beneath the eyebrows and just beneath the eyes. And that's a suggestion that it's been brought on by the sun. How are they arranged? So discrete, meaning that each of those, you can tell that each of those sort of spots within that are all separate from the other ones. Whereas in this one, so you can use the word confluent or coalescing, you can almost imagine it's lots of little brown patches that have all come together in some areas, forming kind of one big patch. When we move on to talk about morphology, this is where the terms get a bit more complicated. So we'll go through those slowly, but some of these might be quite new words that you haven't really come across before or have seen but don't know what they mean. So they can, we begin with ones that are flat, so they're not raised above the surface of the skin. If there's an area of less than about 1 centimetre diameter, we call those flat skin lesions macules. If it's bigger than 1 centimetre, we call it a patch. So that's the distinction between those two. And then if they're raised, again, if it's a little raised thing, and some books say 1 centimetre, some say ½ centimetre, I've just gone with 1 centimetre here. But if they're small, they're called papules. Bigger ones are called nodules. And one useful distinction between those two things is if you can kind of get hold of it between your finger and your thumb, then it's a nodule. And if it's too small to get hold of, if you think of people who've got acne and have spots on their face, you can't quite get hold of those little spots, then we call them papules. Plaque is when it's raised above the skin surface, but it's only raised a little bit compared to the diameter of each of the areas. And then they can be fluid filled, so like blisters. And if they're small, so I've stuck with 1 centimetre on all of these, they're called vesicles. Bully are ones that are bigger than 1 centimetre. And then if they're filled with pus, they're a pustule, and they tend to be small, less than 1 centimetre. So those are probably, that little section is probably the hardest words that are new, but are quite good to know what they mean and to use. And then we can have ones where the skin surface is broken. So if just the very, very top surface of the skin has been lost, it's called an erosion. Losing deeper layers of the skin would be ulcers. And if it's kind of very deep but small on the surface, that's called a fissure. And then we said when we were examining someone that we should inspect and then palpate the skin, touch the skin, and that's to sort of get an idea of the texture. So in some skin conditions, the skin surface feels normal. So like this picture here, if you felt that skin, it would feel the raised bit would feel the same as all the other skin. And that's really important when you're thinking about what could be causing it, because that means it's not something that affects the top layer of skin. It's something going on a bit deeper, and that's why we can't feel the difference. Scale, we probably know what scaly means. There's lots of sort of dry, dead bits of skin on the surface. Crusts form when something's weeping, so you're getting fluid out of the skin, because it's weeping, and then that dries on the surface, and that forms that's what we call the crust. And then maceration is a word that just means the skin's kind of soggy and a bit broken. Typically, it's a typical place that you see that kind of between the toes. And I think in this situation, you probably don't have to palpate the skin because you kind of know what it's going to feel like, and it doesn't feel like something that you want to be touching, really. talk about the colour. So I've not put on the slides kind of simple things like if it's red or brown or yellow or whatever colour, but just more specific terms. So erythema is a term that's used a lot in dermatology, and it means that something's red, but red in the way where if you pressed on this, the redness would disappear because the redness is caused by lots of dilated blood vessels under the skin. So it's not quite the same as just being red, but it is a term for redness. Purpura means bleeding under the skin, so a bit like a bruise really. Hypopigmented means you've lost some of the pigment. So sometimes after the skin's been inflamed in some way, it can be a bit paler afterwards. And that's slightly different to depigmented when the pigment is totally lost because we've got no melanin in the skin. So there's nothing there. It's just white, like those elbows. And things can be hyperpigmented, so have more pigment than they would normally have. And then we look at the border. So this is really important for diagnosing as well. So you can see in this picture here that the border of these skin lesions is really clear. You could pick up a pen and you could draw really neatly what the edge was of all of those. And that's something that we tend to see in psoriasis. So if we're looking at skin problems and you could really clearly mark the edge of them, then that's a well-defined border. And that's a clue towards maybe psoriasis like this rash. If you look at the second picture, it's more difficult there. You could get a pen and sort of vaguely draw where the edge is, but you wouldn't be so definite as you would in the first picture. So we call that a poorly defined or ill-defined border, and that's really typical of eczema. So when we see people with eczema, it's very difficult to draw clearly around the edges of it. So they're really useful ones. Accentuated means when you look at this rash here, the bit that's really most prominent and really obvious is round the edge. And so accentuated means the border of it is more involved than what's going on in the centre. And then shapes can help. So annular means that it's ring shaped. Discoid, annular is ring shaped, so it's clear in the middle. The skin right in the centre of that first one looks very similar to normal skin. Discoid, we can see each of those are round, like coin shaped. Linear, if it's a line. Serpiginous is a term if it's kind of S-shaped or wiggly. And reticular is a word for net-like. So you can kind of see on those legs that there's a network of the purple lines. They look a bit like a net. So, any questions about that? Let's just have a chat about that. Let me come back on here. So I can see it. Yeah, so any questions about all those? It's a lot of words, isn't it?
Do pop any questions in the chat box, or don't forget to unmute yourselves if you're on mute.
No questions? Okay, let me so someone said that it's all clear and they're with it. Okay, so I'll assume you all are as oh, I don't know if I'm not sharing my screen. Let's let me just try and share that back again. Oh, won't be a second. I've just got to get that presentation back up. It clearly doesn't like you going off the shared screen, but I can't see you when I'm on the shared screen.
We can see that again now, Nikki.
Can you? Okay. Oh yeah, you can see it now, can't you? So now that we've gone through all those terms, and you should have those sheets, and I'm sorry for the person who hasn't, have another look at this and try and use the sheet that I gave you as a handout and see if you could come up with more of a description than you did the first time that you had a look at it. I'll give you just a minute or two just to have a think about how you would describe this now that we've been through some of the words. So you have got the terms. We're back in 1 second. I don't know how to. No, I'm still in the middle. Maybe in the break. Okay, so will somebody have a go at telling me what they wrote in terms of describing this?
Poorly defined.
Yes, good. That's really good. That's really important. Yep.
Irregular.
Irregular. Yeah.
Patchy.
Yeah. So when we said patch, we said those were things that were bigger than a centimetre. So I think there are some patches there, but there are also some smaller ones. So what would we say for the smaller ones?
Macular.
Yeah. Perfect.
Erythema and discrete in the chat box.
Yeah, perfect. No one's done the easy one of this, which part of the body we're looking at.
Lower legs.
Yeah.
And
Anyone?
purpuric.
What did you say, sorry?
Possibly purpuric, as in
Yeah.
purpley.
Yeah, there may be some of that actually, mice in there as well.
Symmetrical and multiple, says Gemma in the chat box.
Yeah. Yeah, so I think you've gone through a lot of the things there that we would want to have, and we talked about some things being important, not just to say I can describe this, but how that can help us make a diagnosis. So some of the words you've used might point you in one direction or another. So we had that it was kind of erythema, poorly defined, I think is quite important here, and macules and patches. What would anyone think this was? Did anyone have a think about what they thought it was when they were describing it or not? No. That's fine, because that's the next bit that we're going to do, looking at how we make diagnoses. So is everyone happy to move on to starting the next little bit? I was going to have a break here, but I think maybe we'll do the first case of the next bit, and then we'll take the break after about another sort of 15 minutes or something. So the plan for this next section is we're going to look at the sorts of dermatology cases that we see in general practice. And there are loads and loads of different skin conditions. When you read about it, they say there are over 1,000 different conditions. Some books say 2,000 different conditions, and I think that's if you look at subtypes of things. So it's a massive area. But the majority of things that we see are the common things. And if we know the common things, and then something's not acting like it should do when it's something common, then maybe that's a rarer thing that we need to be getting someone else to help us with. So we're just going to go through some common cases today. And what I thought we'd do is I'll give you a little bit of the history, and you can ask additional questions if you want a bit more history. And then we'll look at how we would describe the rash, and then how that helps us make a diagnosis, and a little bit about how we treat things. But I didn't want to spend too much time on the treatment of each condition, because actually when you've made a diagnosis of something, it's quite easy to look up then, what do I do about this? I think it's making the diagnosis that's the hard part. And there are actually now some apps that you can get on your phone, which I had a quick look at, where you can sort of take pictures of the rash and it will tell you what it is. And the ones I've seen, they're not brilliant. They will come up with some diagnoses, but if you understand a bit about dermatology yourself, you can easily dismiss some of those. It's like, no, it's not that, it's not that, that's a possibility. So I think there'll be a lot more technology coming along to help us make a diagnosis, but I think at the moment we still need to be doing that ourselves. So this is the first patient. So I've put in the history that this first patient is a 6-year-old girl who has had an itchy rash for the last month. They noticed that the rash is worse after a bath, and they said that the dad has asthma. What is there any other questions that you'd want to know from this this patient before you examine them? Anything else you think would be helpful?
Whereabouts is the rash?
Whereabouts is the rash? Yeah, good. And it's on her arms and legs.
Has she had it before?
Not to this extent, no. She's had a little bit, maybe dry skin, but nothing that's been too much of a problem.
Have you got any other family members with skin conditions?
Yeah, good question. No.
Is she systemically well?
Yes. Yeah.
Have you changed anything recently? Changed washing powder or anything like that?
And that's a good question. And I was told many years ago, and I don't know if this is still the case, but I do tell patients it's the case, that if you use the same products all the time, so you have the same washing powder, the companies can actually change the ingredients slightly, and they don't have to make any labeling on their packaging that anything's changed. So we always ask, and it is important saying, have you changed your washing powder or anything? But just in the back of your mind, be aware that we don't know whether the washing powder has actually changed. But as I say, I was told that a long time ago, and I don't know if that's still the case. Any other questions, or should we take a look at this rash?
New foods, what's used in the bath,
Yep.
and immunization status. Does she have any pets at home?
Yeah, good. All really good questions. So yeah, so you've got that history. You've probably got some thoughts of what you might see when you have a look at the patient. But I'm going to show you the next slide, which is a picture of her rash, or part of her rash, and have a think again. You can use that sheet how you would describe this rash. I'll just give you a minute or two, and then if people want to share what they've written, that would be great. So sorry, it's slightly blurry, but that's the rash that they show you.
Right, lots on the chat. Symmetrical.
Yep.
Hang on. Poorly defined, vesicular, all of the above. Erythematous, symmetrical, excoriated from scratching. Heat rash, someone suggested.
Okay. Is that all the things on the chat now? Ruth?
I think I've got all of them. Shout if I haven't. Flexural.
Yeah. So well done. Those were all good descriptions. I'd written on mine, symmetrical. So when you get used to using the words, then you can put them all together in a phrase. So symmetrical, poorly defined, erythematous, macules. I agree, some of those do look like little blisters, so vesicles would be good as well. And I think you mentioned excoriations, which I didn't have in the earlier presentation. There are a few words that will just crop up that we didn't put in there, but can be described in the cases that we've got. And that's when a bit of the skin is damaged from scratching. So that's a clue that that it is itchy. So I think we've talked a few times now about how when things are symmetrical, they're likely to come from inside, that type of rash. When they're ill-defined, that's a good clue towards someone having an eczema type presentation. So those words are useful to make a diagnosis here. What does anyone think it is? You can type it in the chat or just shout it out, would be easier for me.
Eczema?
Yeah, so this child has atopic eczema. Atopic eczema means the kind of eczema that you get in combination with asthma and hay fever. So in the history where dad had asthma, that was a little clue towards having the child having eczema as well. You often get those three conditions all coming together. So atopic eczema is really common in children, but you can have it at any age. A lot of children grow out of it, but for some, it persists into adult life. Eczema is usually very itchy. So if something doesn't itch, it's unusual for it to be eczema. And we said in the history for this little girl that it was worse after a bath. Do you think that's relevant?
Heat can flare it up, make it itchy.
Heat can make it itchy, definitely. And I think that's one reason that a lot of people itch at night when they're warm in bed. And not just the heat, but water makes eczema worse. And people don't always realise that because they think, well, my skin's really dry and it actually feels quite nice to be in a bath. And it is quite soothing, but water has a real drying effect on the skin. So when you get out of the bath, the heat and the water make it look more red, and the skin will be quite dry if you keep getting it wet. So water is a trigger to the eczema, soap even more so. So if you're putting bubble bath in the bath or using soap to wash with, all of those things will flare it up a little bit. The other thing just to say about eczema, it means the same as dermatitis. So when you see things that call something a dermatitis, whether you use the word eczema or dermatitis, they're both the same thing. So you might just see that somewhere, and that can be a little bit confusing, but they're the same thing. What else was there in the history that we had of this? Yeah, we talked about triggers, water, soap, heat. Other triggers that might flare up people's eczema are things like the clothing that they wear. If you get infections in a bit of the eczema, it will look worse. Pets, so things someone mentioned about in the history what pets they had, that's quite relevant. You can get eczema because you're allergic to the dog or the cat. Foods, and I think you said that about the history, any new foods. And my house dust can flare up eczema as well. So these are also pictures of eczema. This isn't atopic eczema. These are different kinds of eczema. Anyone want to tell me what they think the one on the left the leg. What kind of eczema is that? Oh, sorry. What kind of eczema is that? It was, sorry.
Discoid eczema.
Oh, yeah, the one at the top is discoid eczema. I was meaning the leg one, but that's fine. Yeah.
The varicose eczema.
Yes, so varicose eczema or venous eczema for this one. It's not a brilliant picture of it, really, but you would see, again, ill-defined kind of redness on the lower leg and in people who've got varicose veins, so varicose or venous eczema, and that tends to be itchy as well. And then whoever said discoid eczema, absolutely right for this, the one up at the top. And although at first sight you think, well, that's quite well defined, I'm not sure that they are really. If you got your pen, I think you'd still be thinking, well, is that the edge or is that the edge? It's not quite a neat outline like we've seen on some other pictures. So discoid eczema, it tends to affect people in their 40s, 50s, 60s, that kind of age group usually. And again, it's very, very itchy. And the one at the bottom, the man's, tell me what kind of eczema is that? Any ideas?
Contact dermatitis?
Yes, perfect. Whoever said that, that's great. It is a contact dermatitis. So things that we would have here is we've just got one patch, which is quite unusual because eczema tends to affect an area. And it's just on one side of his body, so it's not a symmetrical rash. And we talked about things when they're not symmetrical being maybe coming from something external. What do you think has caused this rash?
He's allergic to his belt.
His belt. So the metal from his belt has triggered off an eczema there. So, you know, if somebody showed you something like that and there's just one patch and that's unusual and it's just on one side of the body, then you would be starting to think, well, is it something external that's caused this? And you're absolutely right. The picture's really nice because it shows you that metal belt and that's what's triggered that off on his tummy. Good. And these are just some pictures to show you a lot of patients we see have white skin, but skin conditions do look different in people with pigmented skin. So the picture on the left, someone who has a darker skin, where this is eczema on their skin. And what we tend to see is where we're talking about erythema and kind of red patches, you often see in darker skin that the patches just become a bit darker than the normal skin colour. So they tend to look grey or brown. Sometimes they look red, but just to be aware of that when people have got different skin types, things can look different. The picture on the right is a picture of eczema in black skin. And in black skin, people very frequently get what's called a papular eczema. So we talked about papules being raised, things that are smaller than a centimetre. And you can see all those papules on that skin. So that looks very, very different to the child that we've just looked at. And that's a presentation in black skin. So it's worth just being aware that things don't look the same in different skin types. So we're going to move on to treatments. I think we'll just do the treatment of eczema and then we'll take our first break, if that's okay, just so we've kind of done the little eczema section. So I think when we talk about treatment, we kind of think, what am I going to prescribe for this person? What would be the best cream to give them usually in dermatology? So we're thinking about different creams, but there's something important before that. So before we think about the exact prescription that we're going to write, there's a lot of other things we can do that are really helpful to patients. So in terms of things like, if the patient's got eczema, that's a chronic long-term condition. And so it's a big deal for these patients. And the more education that we give them so that they understand about eczema and what it is and what makes it better, what makes it worse, that's all really, really useful. It's not just about the actual creams. The other thing that can be really useful in patients, in a lot of dermatology conditions actually as well, is thinking about the costs of all these things. For a 6-year-old girl, they're not going to pay for their prescriptions, but if you've got an adult and they're having to pay lots of money to get lots of different creams, just telling them about prepayment certificates and how they can cover the prescription costs is really useful as well. And so I think it is quite useful to give people as much information as you can, and there is a National Eczema Society. Directing people to that is really helpful to them. And then we think about what creams to prescribe once we've done that kind of education bit. I'm going to talk later in this session about specific creams, so we'll just be a bit vague here. The big bottle is to represent emollients, so we give people big bottles of moisturizers, which is really important for the dry skin, and topical steroids. That's the mainstay for eczema is emollients and topical steroids, and they need both of those. Sometimes if people's eczema is really bad, you get into putting bandages on and wet wraps and things, but not particularly going to talk about that, just the basic management of it. So when we need people with eczema to use emollients all the time, and when their skin flares up, like that little girl, and it's a bit red and itchy, that's when you can use topical steroids. And some patients and some doctors are a little bit scared of using topical steroids. But if you use them safely, they are safe to use, and we'll talk about steroids a bit later. If patients are having flare-ups of their eczema repeatedly, then there are things you can do. So if you're having more than, if you're getting a flare-up less often than every couple of months, they now advocate that some patients can put on steroid every weekend and not do it during the week, and that helps to just keep things under control. So that's a kind of new way of treating that, really. And we talked about, when we were saying about examining patients, we talked about you're supposed to do this systematic check, and lots of people with eczema have eczema on their scalp and they don't always mention that, so it is worth just checking about scalp as well, and there are treatments you can give for that. So I think, any questions about eczema? Ruth, is there anything in the chat?
Someone's just typing as we speak, so I'm waiting.
Oh, okay. So we'll wait for that, that's fine.
No, very clear, thank you.
Okay.
Do children often grow out of it?
Yeah.
Question in the chat.
Yeah, lots and lots of children do grow out of eczema. So it is very, very common in childhood. And I would say the majority of those grow out of it, but also people get, if they're treated well, they will just naturally carry on using emollients and looking after their skin and avoiding those triggers that make things worse. So I think in addition to it disappearing, they also learn how to live with it and so manage it a lot better, because to them it's normal. Any other questions? Okay, well, we'll take a break now. So it's 10:20. So 10 minutes and we could start again at 10:30, if that's okay.
Yeah, lovely, thanks, Nikki.
Okay, thank you.
Hello? Speaking. Oh, right, I haven't got a chance. I'm on a course at the moment, so I'm about to talk. Later on tonight. Alright then. Thank you, bye.
Okay, so we'll just wait till it's 10:30 and then we'll start again if that's okay. I don't know if everyone's back, so I won't start it until my clock says 10:30. Can I just check if I've changed my settings on my computer, so can I just check if you can see, can you see the shared screen again?
Yes, I can see you. Hi.
Yeah, yeah.
And does that look the same as when we when I had it before, the slide that I left it on?
Yes, yeah.
Okay, that's good. Because I can see you now. I couldn't see you and my slides before because I'm not, it's quite new, all this doing things over electronically. I've done a lot more face to face rather than this. And I had a little practice run with a colleague, a trainer in our practice, but that was just one-on-one. So I could see her, but I couldn't see any of you when I was doing that last time. So that's good. So we'll carry on from where we're up to. Anyone thought of any questions about eczema that they wanted to ask over the break or anything? Just ask, you know, speak it out or type it now if there are any.
Is there any benefit from antihistamines?
Yeah, I think there is, and it's not something that I do routinely with people, but if the eczema is very itchy, you do make things worse by scratching it, and you know, there's this sort of cycle that when you scratch you release histamine and histamine makes you itchy, so you get into that vicious circle, and to break that, antihistamines can really help. So I would probably do it as a short-term thing rather than a long-term thing, because hopefully the creams will be healing the eczema and making it less itchy, but it can definitely help. And especially things like Piriton at bedtime, if people are scratching a lot in their sleep in the night, that can really help as well.
Thank you.
Anyone else? Okay, so we'll move on to patient number 2. So for this patient, it's a 30-year-old man, got a rash for the last 3 months, which is not itchy. He is a smoker. He does drink a reasonable amount of alcohol every week and has no family history. Oh, can you see that or not? She just said that you'd lost it.
No, that's gone down, Nikki, now, the presentation.
Oh, I wonder why.
You
can see it now, can't
let's back up.
you? Can you see it now? Can you see it? Can you see it now?
Yeah.
Okay, hopefully that will stay there. So there's a bit of the history. Any other questions that you want to ask this person who's got this rash? Oh, sorry.
Occupation. Medication.
Occupation. Yeah, I haven't said that. Yeah, works in an office. Medication. Nothing particularly, nothing new, not on any regular medication, pretty fit and healthy. Where is it?
Where is it?
Knees and elbows.
Change in sexual
Okay.
partner?
No. And what has he tried? Tried putting a bit of moisturiser cream on, but didn't really help. What else have we got on here? Diet, allergies, no allergies, normal diet. Any stress? I think everybody can always think of some stress, but no, nothing in particular. Family history, yeah, there's no family history, that's fine. How much moisturiser? Yeah, good question. And that's something that we don't always ask when people say, I've been putting moisturiser on it once a day for the last few weeks. Do you want to have a look at it? Any pain? No. What kind of pain were you thinking about? Anything in particular? Tracy, put that question. Liver, joint pain, that's a good question, well done. No joint pains. Just thinking about liver pain, no. Should we take a look at the rash? Okay, so again, have a think how you would describe this rash. This is the two elbows.
Scaly.
Scaly, definitely, yeah.
Symmetrical.
Symmetrical, yeah.
Dry.
Dry. Yeah, it looks dry. And I think dry and scaly are kind of similar. Things that are scaly are dry as well. Yeah, so it looks dry, scaly, symmetrical.
Flat patches.
Yeah, they do look like flat patches, don't they, on that picture? And it's really interesting, isn't it? Because I always think looking at pictures isn't as good as really seeing something, because you don't tend to get as good an impression as in real life. And I've always said to people, you know, when we're teaching, you obviously end up looking at lots of pictures, but actually that has become real life now, hasn't it? With coronavirus, I don't know whether people are working like we are and patients are sending in lots of pictures, and we're doing a lot of the diagnosis now using pictures. So actually to get used to looking at pictures is a skill that we need at the moment. So yeah, someone else has said plaques, and knowing what the diagnosis is, we would describe these as plaques, but I do agree, if it was flat, it would be a patch. If it's raised slightly above the surface, but not raised too much, a lot wider than it is high, it's a plaque. So yeah, there's people that have just put plaque on the chat. Absolutely right.
Also on the bilateral.
Bilateral, yeah. Anything else? I don't think. Oh, I'll tell you. There's one thing that you haven't mentioned that would be good. What about the edges of this rash? Well defined, poorly defined.
Poorly defined.
Yeah, it's a tricky one, isn't it? Because parts of it do look a bit poorly defined, especially kind of over here. Can you see that where I'm pointing to on that slide? I think around this bit here, it seems a bit poorly defined, but other bits of it are really quite well defined. And what do you think this is? What would you be thinking when you've got the history and you've had a look at these elbows? What would you be thinking it is?
Psoriasis.
Yeah, and the key thing about psoriasis is that really it's well defined, which is why it's odd that this one, I agree, doesn't look that well defined, but generally psoriasis is thought of as being well defined. So I had very similar on my list. I put symmetrical, well defined, scaly plaques, but that's probably because I know what it is. And you tend to get that on the extensor surfaces. So I don't think I said that about eczema, but eczema tends to be on the flexor surfaces, so at the front creases in the elbows and the back of the knees. Psoriasis is the opposite and tends to be on the extensor side of the elbow, like it is here, and on the front of the knees. Those are common places to get psoriasis. These are just some other pictures of psoriasis. So the one on the left, if you get psoriasis in skin folds, it isn't scaly. So you would be mistaken. You'd think, well, this doesn't look like psoriasis, because psoriasis generally is very, very scaly. But when you get it in skin folds where it's all a bit moister, you just get redness. Still well defined around the edges, but there's no scale. So you would be forgiven for not thinking this was psoriasis. But if they've got psoriasis elsewhere and you see this in the skin fold somewhere, then that may be psoriasis as well. And what about the right hand picture? This is a kind of psoriasis. What was this kind of psoriasis called? Guttate psoriasis. Yeah, Michelle just put that in. Yeah, I'm gay. Perfect. So I don't know whether you all know about guttate psoriasis. This is a form of psoriasis that you get that usually follows a sore throat. So a typical story would be that somebody's had a sore throat and then they wake up one day, a couple of weeks later or a week later, with all these little pink spots, and they're described as like raindrops. So it's like someone's just put lots of spots dripped onto the skin, and you tend to get it mainly on the trunk. It's not usually itchy, but people are quite alarmed when they wake up covered with all of these. So it's something that we see not that infrequently. And guttate psoriasis is the patches look like psoriasis that we've just described. It tends to not be particularly serious. It will clear up on its own, and some of them go on to develop psoriasis, others don't. So it's not a given if you have that at some point in your life that you will be prone to having psoriasis later on. It happens in some, but not all. The other things with psoriasis, if you look at the left-hand picture, that shows, it is put on to show scalp psoriasis. Really, it's very common that psoriasis affects the scalp, and it's really tricky for those patients. They find it quite distressing because they get lots and lots of dandruff all the time. There are lots of good treatments for that, but you can also see the nails in that patient are all affected as well. And so this is some point where we really should be looking at the scalp, looking at the nails. This is why they're saying that, because if someone's got a rash and they've got nail changes, do you know what nail changes you get in psoriasis? Pitting, yeah, Michelle put on the chat, pitting. I don't know if you all know what that means. Pitting means you get little dimples in the nail, so it looks a bit like a thimble. The nails can be thickened. That's right. Anyone else? And you also get what we call onycholysis, which is a complicated word, but just means that a bit of the nail separates from the nail bed, so you get kind of white spots in the nails. The other picture, the one on the right, that's another picture of psoriasis, and that's extremely scaly. And psoriasis tends to be much more scaly than eczema, and you can see there's so much white scale on the skin, particularly here. And that's really important when we think about treating psoriasis, because if we put some psoriasis treatments on this, it's not going to treat the underlying psoriasis, it's just going to soak into all that scale on the top. So there are treatments you can use to get rid of the scale, and if you use that first to get rid of the scale, then other treatments will work, because they won't be just getting absorbed into that top layer. So what do you know about treatment of psoriasis? Anyone know how, anything that we would use to treat psoriasis?
Specialist shampoos?
Specialist shampoos, yeah. Do you know the names of any shampoos?
No, I don't.
No idea, that's fine. So, I mean, in terms, we'll talk about the scalp. In terms, sorry? Oh, we'll talk about the scalp. In terms of, you're absolutely right, specialist shampoos. Somebody's put on here Betacap, which is a steroid solution you can put on the scalp. You need to use treatment to descale, like salicylic acid, which is, and that's the key point really. So you can use specialized shampoos. They tend to be coal tar shampoos, work really well. I always use one called Capasal because it's quite a nice shampoo. It does smell of coal tar, but as we said with that last picture, if it's really thick with scale, the shampoos are going to struggle, and you can get something called cocoa ointment, which is salicylic acid, and that will remove the scale. So treatment with that, if something's thickly scaled either on the skin or the scalp, is really, really important to get rid of that thick scale. And that's maybe where we go wrong sometimes with psoriasis. You can put other treatments on, but if it's very thickly scaled, they're not going to work. So Betacap that's been put on the chat, if the scalp's very itchy, then the steroid helps with that. Psoriasis doesn't tend to be itchy, but it can be a little bit itchy, so it's not unusual to have a bit of itch. And steroids will treat psoriasis, but they're not the best treatment for psoriasis because you can't use them long term in psoriasis. They can cause flare-ups in themselves. Just putting something else in the chat. Let's have a look. Oh, I don't know. So it's really important again with psoriasis. It's a chronic condition again. The education side of things is important, directing them towards psoriasis websites. All of those are important. We use emollients, and emollients on their own, so they're moisturizers, they can have an impact. And if the psoriasis is mild, that might be all that people need. But usually people need a bit more than that. So calcipotriol, which Rebecca put on the chat, is a really useful treatment in psoriasis. So that comes with a steroid in it, which would be called Dovabet, or on its own, just calcipotriol, which is Dovanex. And those are probably the most common treatment that we use in people, and they work really well. The combination one with the steroid tends to be what people use first, and it gets things under control. You can't use that continuously for more than 8 weeks. If you've used it for 8 weeks, then by that point you should be able to switch to the Dovanex, because you don't want to be using the topical steroid all the time. So that's really important just to look out for. If people are only using the Dovabet, they should be having a break from the steroid every 8 weeks. And nice guidelines now, so you can have Dovanex in the morning and a steroid at night rather than the combination, and stop the steroid intermittently. You can use coal tar to treat it. There are coal tar creams. You have to be really careful prescribing those. I always use Exorex, which is a coal tar cream, but they all moisturizer, so you have to check that you've picked the right one off the list. Flexural psoriasis, so where we saw the one under the lady's breast, they usually respond really well to a topical steroid, just a mild one, so hydrocortisone, and you can have some antifungal cream in that as well. So something like Canesten HC is a common thing to try using there. And then there are lots of treatments, secondary care, which we can use if those aren't working. So we'll move on to patient 3. So this one, we've got a 25-year-old male who's got just one itchy patch, got slowly bigger over the last months, not had any other skin problems, tried a bit of moisturizer, no better. Do you want any other answers to any other questions? Where is it? I'll say on his tummy. Has he had it before? No. Any pets? Has a dog? Any allergies? No. Does anything make it better? No. Anyone else got it? No. Yeah, he's well. He's well. Yeah. So, unwell before? No, been completely well and just developed a rash. So again, you can have a look at that rash and think about how you would describe this one. Obviously, we've only got a close-up of this, but it is just a single patch, and I said it's on his tummy. So you can speak or put in the chat what words you would use to describe this. Annular single lesion, really good. Defined edge, yeah. well-defined edge. So yeah, I agree, it is well-defined. If you think back, I know there was a lot of words to give you, and we had well-defined, poorly defined, and one other description on that presentation about the edge. What, can you remember what that one was? Or you can look it up. Accentuated, absolutely. And I think the point here is that in the middle, the skin's pretty normal, but around the edge, that's where it's all red and scaly. So accentuated border, this is the time when it's good to use that term, and that helps with the diagnosis. Scaling, somebody's put, yep. Okay, so, oh, erythemic edge. Yeah, so there is erythema there as well, isn't there? So you've probably now said all the things that I'd put on mine: asymmetrical, because there's just one, single, scaly, erythematous, and it's going to be a macule or patch, depending on how big it is, but with an accentuated border. And I was going to say then, so what does anyone think it is? And someone has already put that in the chat a bit higher up. And they were absolutely right. They put on there that they thought it was ringworm. Tinea corporis is the kind of dermatological term that they use for that. So tinea is a fungal infection, and the corporis bit means it's on the body. So ringworm is what people often use when they're just generally talking about this. And what tends to happen is you get a little scaly patch and it grows bigger and the middle heals, and that's why you get that accentuated border. The other thing that's important when you see somebody and you think it might be a fungal rash is to have a look at the feet. And sometimes they've got that fungal rash because they might have some athlete's foot, and that might be where the source of all that is. So it's a really good idea to have a look at the feet, to have a look at the groins, or ask them about the groins, because those are areas where people sometimes have fungal rashes that they don't particularly know about, or that they think is just normal to have kind of a bit of itching between the toes and a bit of skin peeling. And how are we going to treat this one if you see someone with a fungal rash? Antifungal cream, we've got in the chat, absolutely right. So generally we would give a topical antifungal cream. And what would you do if you gave someone Canesten or something, which would be a typical antifungal cream to give them, and they came back 2 weeks later and they said it's no better, it hasn't done anything? What would you be thinking at that point? Okay, let's have a look. So we've got here, continue and make sure that they're applying it correctly. And I guess if they're not applying it correctly, then it won't have worked. So it's reasonable to find out why it isn't working. Someone says bacterial infection. Doesn't really look like a bacterial infection, but it's good to think about other things, you know, and think, is my diagnosis right? And I think that's something always worth thinking about when the treatment that you think works shouldn't work. And then Gay's put on the chat, maybe resistance to that fungal cream. And yes, and Gemma's put maybe terbinafine. So absolutely, that's what I would be thinking. So what we find is sometimes the antifungal cream doesn't work because there's two different categories. There's things like Canesten, which is clotrimazole, and miconazole, and all those ones ending in azole are like one group, and terbinafine's a different group of antifungal cream. So if your clotrimazole or whatever doesn't work, then it's really worth changing to terbinafine. The other thing that you can do is you can take scrapings of the skin and send them away to look for fungus. So if you're not getting anywhere with the treatment, then that's something worth considering. But you have to have been off any treatment. So you can't have had any steroids or antifungal creams or anything on the rash for about 2 weeks before you take the scrapings, or you don't get a proper result from that. And patient 4. So here we've got a 30-year-old lady who's had a really itchy rash for the last 3 days, and she said it just comes and goes, and it's in different places at different times, affecting the whole body. Not changed any products like soap or washing powder or anything. Any more history that you want from this lady? Where is the rash? Everywhere. So she gets the rash in different places, but it comes up somewhere, and then it goes, and it comes up somewhere else, but everywhere has been affected. Social history, she could work as a nurse. No other particular hobbies or anything. Is she well? Any known allergies? Yes, she's well, but fed up with all the itching and not known to be allergic to anything. Is she well? Pregnancy? No, she's not pregnant. She's feeling well? Yeah.
She taking any medication?
No medication, just fit and healthy 30-year-old suddenly affected with this rash. What does it look like? Well, yeah, it's a good question. We'll have a look at it, and then you can tell me what you think it looks like. Anything make it worse or better? Not that she's noticed. When does it come and go? For example, is it worse at night? It just comes and goes of its own accord. It doesn't seem to be particularly tied in with anything. Any contact with plants, gardening? Good question. No. I'll say in her case, no. Anyone else had this in the last 6 weeks? No, nobody that she knows. So let's have a look at it. So this is the bit of rash that she's got at the time when she comes in to see you. How would you describe this rash?
Is there a term geographic?
I only know that's a term in like geographic tongue, which is a specific thing. So not that I've seen commonly used. Is that what you thought might be used?
Yeah, it just looks like island.
Oh, I see what you mean. It does, doesn't it? No, I understand that, but I don't think there is a term that would.
No, you're right. It's on the tongue, isn't it? But yeah.
So we've got here ill-defined. I'd probably go for well-defined, but papular, symmetrical rash, wheals, good, widespread. Wheals is one of those words that's on the sheet, but I didn't talk about specifically. Widespread, really good. Oh, reticular is an interesting one for that, because I can see why you would say that, but it probably isn't strictly, and I guess that's because the way that they've sort of joined together. Confluent, yeah, that's what I was talking about. So it looks like we've got lots of, you can almost imagine, like, let's just put that pointer, that you've got little discrete things here, and then they're confluent and have joined together to create the bigger patches. Raised, absolutely, it's raised. And when we talked about raised lesions, if we had to go for one of those things when they're raised, where we had papules and nodules and plaques, which of those would you pick in this case? Erythema, absolutely, whoever put that on the chat. Well, I'll answer my question. You would put it as a plaque because it's raised, but it's not very high. It's much wide. They're then much wider than they are high. But whoever put wheal on, that's absolutely the right word to use here. And what wheals mean, and you have got it on the sheet, it means that you've got a lot of fluid, inflammatory fluid under the skin, and that's what's causing it to be so red and raised. And the really important thing here is, what would it feel like if you touch this skin surface? Anybody want to say or type? What do you think the skin would feel like? Warm? Someone says warm. It probably would feel warm, yeah, and patients do tend to talk about their skin feeling burning and feeling hot. And Michelle's absolutely right, it would feel the same as the other skin. There's no scaling here, and that's because what's happening is there's lots of fluid underneath the skin causing these, rather than anything happening on the top surface of the skin. So what do we think this one is? Speak or type? Urticaria, absolutely. So yes, lots of people have typed urticaria, and absolutely that's the diagnosis here. And hives is a sort of colloquial term which means urticaria. And I think someone put something interesting in the questions when we were doing the history, when they said, what does it look like? And I think in urticaria, that's one of those things that's really useful to ask people, because or you can say to people, does it look like when you get stung by a nettle? Because most people know what nettle stings look like, and it's the same kind of reaction that we get here. And we used to find, because one of the key things in urticaria is that each of the individual red areas lasts less than 24 hours. So if they've got something that's come up and it's itchy and it's red and it looks a bit like this, but it's been in the same place, the same things for more than 24 hours, then it's not urticaria. So that's a really useful thing to know. And they do just come and go at random, and they can just come and go very quickly. And we used to get a lot of people who'd come and say, there is nothing to show you at the moment. And those are the people you can say, well, does it look like nettle stings when you have it? But with the use of phones now, you get people saying, there's nothing to show you, but I've got loads of pictures on my phone. So that's another place that pictures are really useful. And so the important things in urticaria is the skin surface is normal, the patches come and go, wheals look like nettle stings, and they come and go, and the skin surface is normal. I think it just, yeah. So how do we treat urticaria?
Antihistamine.
Yeah, so a few antihistamines in the chat, and thank you, Mike, speaking to me. It's nice to have someone talk. Yeah, so antihistamines are really important, but if we think about the treatments, and we went for that first one about education and what we can tell them, I think that's really important as well in urticaria, because it's a really, I really love urticaria. I think it's a really nice condition, but I think people hate it if they've got it, because it's really unpleasant being itchy all the time, and antihistamines will stop the itch. What would you do if you gave someone an antihistamine, say cetirizine, and it wasn't working, and they said don't feel any better, they're taking their cetirizine in the morning and they're still itching and still coming up in these blotches? What would you try with a patient like that? Okay, change the antihistamine, fexofenadine, try fexofenadine. So yeah, people are also the same thing. And so antihistamines are really interesting in urticaria, because there's no logic to the fact that if one antihistamine doesn't work, another one might do. So it's always worth trying 2 or even 3, and they're all the same group of things. They should all work in the same way, but it's well known that if one doesn't work, another one might work really well. And then someone else has put in the chat, increase it out of the license. And that is something that you can do in urticaria. You can definitely take your antihistamine twice a day. And the guidelines do say you can take it up to 4 times a day. I've never prescribed it that high a dose, but I will go to twice a day in people with urticaria, where the once a day helps a bit, but it doesn't help for the whole day. You can use oral steroids in urticaria, but they try really hard not to, because it can last for quite a long time with people, and you don't want to be on steroids for a long time. So lots of dermatologists say maybe a short burst of a few days if there's something important that they're doing where they just can't be dealing with this itchy rash, that's the only time really that would be used. And then if you look up the treatments of this, you can try H2 blockers, or I think Montelukast is another one that can be tried. Patients often want to know what's caused it. Am I allergic to something? Is it going to happen again? Usually if it's caused by something like a food or something that they've eaten or been in contact with, people usually know and think, well, it happened when I did that. Just kind of blindly looking for, am I allergic to something, doesn't give many answers really. And you do find people who've been to A&E and been told, you've got an allergy to something, go to your GP and get some allergy tests. And it's really frustrating because we can't really do just allergy tests. You have to have a bit of a clue. And someone just put on the chat, stress related, and I think you can get urticaria that is stress related. And I think also for some people it's unknown, so we never know what triggered it. And the thought with that is that it might be some viral thing that we don't really know about. So looking for a trigger, if it's not obvious, is really, really difficult. And for most people, it settles down after a few weeks. It can become chronic, and if it becomes chronic, that's when I have to look it up, because there's all kinds of extra tests that you can do. Chronic would be defined as more than 6 weeks, which is a miserable thing to have. So patient 5, little child, 3-year-old boy, had a rash on his chin for 3 days, not itchy, not had problems with his skin before. Any other questions, or do you want to have a look at it?
I'm already thinking tiger.
Yeah, and that's what's making you think. So, and I think we do that, don't we? When we listen to history, we think, oh, I think I know what's going to be wrong with you. And I've only put up a few things there, but you maybe don't need any more than that. So people have just added on the chat, is he well? Yeah, apart from this, he's fine. Dribbling? No. And this is how it looks. So how are we going to describe this rash in this little child? Someone said, does it have a crust? Yeah. Crusty? Yeah. What's going on under the crust? Sorry, Mike, what were you going to say?
Defined.
It is well defined, isn't it? Yeah. Erythema. Yeah, so we've got kind of well defined erythema. And in terms of symmetry, asymmetrical, symmetrical, where are we going? Erythema, patches, bulla. Well, you can, I don't know if there is on that picture. So bulla are like large blisters. I don't know if there is on that picture. It's always difficult with a picture to be sure. Asymmetrical. Yep, Michelle. And asymmetrical is really important, because we've already said when things are, they've come from inside, and when things are asymmetrical, we're looking at something external causing it. So asymmetrical is important here. The crust is important here. And I'd written on my sheet that you have erythematous macules, which I guess are joining together, coalescing with exudate and a crust. And the typical description would be a golden crust, so it's quite yellowy when you look at it. And Mike said that it's impetigo. And I didn't jump straight onto that impetigo, because I think it's quite nice to just try and have a think about how you describe things first, so that you're building up a picture of what is it about that makes me think it's impetigo. But it is. And how we're going to treat impetigo, we're probably all...
Sorry, Nikki, is there a reason why does it so often affect the chin?
Why does it what, sorry?
It seems to be on the chin very often. Why is that?
Oh, let me just, sorry, my phone's ringing. Yeah, I don't know why it affects the chin so often. Yeah, I don't know. I mean, because you do tend to see it mainly on the face, around the nose as well, and on the chin. And it might be partly because we tend to touch our faces quite a lot. If you just watch somebody, they tend to touch that area of the face, and so perhaps that's how they're spreading it to the skin. Someone mentioned about dribbling, and I think in tiny children, rashes around the mouth are often caused by dribbling, but I don't specifically know why it affects the chin particularly. Sorry. So yes, we've got in the chat some treatment options: topical antibiotic, or Fusidin, which is a topical antibiotic, or Bactroban, another one. Yes, so antibiotics are the treatment because it's a bacterial infection, so either topical or oral, and I think the decision would be based on how extensive it was. So if there's just a small patch of impetigo, then topical will help. If it's a larger area, then you might need an oral antibiotic. Oh, Michelle says hydrogen peroxide cream, not something I've ever done. Do you want to tell us some more about that, Michelle? You could go off mute and tell us if you like. Oh, new NICE guideline. Okay, so, oh, you've got no microphone. Okay, that's fine. So Michelle says hydrogen peroxide is in the new NICE guideline and she doesn't have a microphone. Okay, interesting. I obviously need to know about that. So patient 6 will just do, this patient's 45-year-old man, had a pain in his shoulder area for a couple of days and then developed a rash, feels a bit like he's got flu. Any other questions that you'd like for him? Okay, so we've got here viral rash. Is it painful? Yeah. Is this a blistery rash? Well, we'll have a look in a minute, but yeah. History of chicken pox? Yes. Where is it? Just in the shoulder area, one-sided? Yeah, I think we probably need to look at it because these questions are just telling us what we're going to see. So have a little think, how are you going to describe this one if you see this rash? Ouch, yes, that's a good description.
Blisters.
Blisters, yeah, and you can see the blisters on this rash. And what's the if fluid-filled vesicles? So vesicles are those small blisters. It's unilateral. You can see the cut off in the middle of his body. Shingles, not a description of the rash, but a description of what he's got. Erythema. Yeah, so I would say it's an erythematous background, and then there's multiple grouped vesicles and maybe some pustules. Even looking at that, they sort of look like they've got coloured patches in them. And as you said in the chat, Tracy put on there shingles. Oh, Tracy put on there shingles, and that is what it is. So I mean, it's a very typical rash, and that cut off at the midline is really important there. And then the skin going through the stages of being red, getting a blister on it, and then scabbing over. And somebody mentioned chicken pox, which is obviously really important because shingles is the reactivation of the chickenpox virus. Do you know how we treat shingles?
Acyclovir.
Acyclovir, yeah. And you need to try and get in early early in the rash. The earlier you treat it, the better. So yep, acyclovir within 72 hours. Perfect. And I think. Oh yes, sorry.
Can you carry over the 72 hours if the rash is still spreading?
Yeah, 72 hours is the ideal time. Within 72 hours is the ideal time to start the acyclovir. But if you see someone, the following day or whatever, then I would still, I would still try that treatment, because shingles is really horrible. The biggest problem is the pain that you get after shingles, and treating it tries to reduce the amount of pain that you get post-herpetic neuralgia. So I think, and acyclovir is pretty safe. So I think it's worth still giving them acyclovir, even if they're beyond the 72 hours. Shall we just have another break now? If we say another 10 minutes, is that okay? And then we've just got a couple, the last couple of patients in this section, and then we'll do the treatments as well after the break.
Lovely, thanks, Nikki. We'll see everyone back at about 25 past.
Yeah, so 25 past, we'll start again. Okay, have a break, have a drink, walk around, and I'll see you again in 10 minutes. Okay, we'll just wait until it's 25 past and then we'll carry on. Okay, so it's 25 past on my clock. So we've got a couple more patients to do, and then we're going to look at the topical treatments. So this is patient number 7, 25-year-old lady with dryness, itching, both hands, getting worse over the last few weeks. She did have eczema when she was a child, but not had anything since. She's been using hand creams, but it's not really helping. What else would you like to know about her?
Job.
Her job, yeah, hairdresser. Anything else?
Does she wear gloves at work?
Good question. Yeah, no, she doesn't wear gloves. Gemma's put on the chat, are there any vesicles? No. Is she well in herself? Yeah, she's absolutely fine. Just these hands are driving her mad because they're so itchy. Any other questions, or should we move on to the, oh, maybe something, we could move on to the picture. So you have a look at her hands, and this is what she shows me. Oh, we've got a couple of other questions here. Is she washing her hands more than normal? No, not more than normal, but she does wash her hands a lot and they get wet at work because she has to wash the people's hair. Change of products? No. Previous history of allergies? No. How are we going to describe this rash? It's quite tricky, I think. When you have a look at that. Anyone want to speak or put into the chat? Dry skin? Yeah.
Fissures.
Yeah. So we've got words here: erythematous, fissures, dry. So I think dry probably means scaly, really. Asymmetrical. Yeah, there's certainly the hand on top looks worse than the hand underneath. I don't think I had any more. I mean, it's really difficult to tell, isn't it? Because there is erythema on that picture. Do you think it's well defined or poorly defined where you can see it? Because it's quite red around here. A well defined edge or not? How would you? Poorly defined, yeah. So you've got poorly defined edges. So we've kind of got redness, so erythema and scaling, poorly defined edge and fissures. So hopefully from things we've already said, if we've got something that's poorly defined, erythematous, scaly, what kind of thing are we thinking of here?
Like an eczema, contact eczema.
Yeah, contact dermatitis, and so we've had a little bit of that on the chat there, and you're absolutely right. So those, and that's why I think it's quite good to think about describing what you see, because that poorly defined, scaly erythema sort of says eczema in your head. And as we said before, eczema, dermatitis are two words for essentially the same thing. So this is hand eczema or contact dermatitis. They're kind of all describing the same thing. And this is a really important condition. And actually, we're seeing lots of it at the moment because of washing hands more. So what triggers do we know? Why do we think this lady's developed this contact dermatitis?
It's probably occupation related with washing hair all the time.
Yeah. So water's really drying to our skin. And the other thing in the history with this lady was that she had eczema as a child. So when we talked about atopic eczema earlier, and you tend to grow out of it. She's probably one of these people, but they get very prone to hand eczema later on in life. So there's often a history of having had eczema as a baby or a young child and then developing this contact dermatitis in later life. And occupation wise, that can be a big issue because things like hairdressing, where your hands get wet a lot, nursing is another one where people wash their hands a lot. It can have a big impact on your occupation if you've got bad hand eczema. What do you know about treatment of hand eczema or contact dermatitis? Product use, someone's put on the chat sheet. Yep, so by product use, do you mean changing what products you use? I'm not quite sure, but if it's something that you're coming into contact with, so particular shampoos or cleaning products or something that's triggering it off, you could change those. Emollients, avoid irritants. Oh, that's really important. Gemma's put that on the chat. And there's two different kinds of contact dermatitis, where you're actually allergic to something that you're coming into contact with, and irritant contact dermatitis, where the skin is just being irritated by things, and the irritant one is much more common. So again, this is a condition where people think, well, what am I allergic to? What's triggered this off? And for a lot of them, they're not allergic to anything. Their skin is just being irritated, and the most common irritant is just water and soap from washing your hands. And you see people who've got quite bad hand eczema who find it really soothing to sit with their hands in a bowl of water because it doesn't itch when they're in water. But the end result of that is it's going to get even drier because of the water. And this is one condition where the patient education is really, really important. There's a really good information sheet about caring for your hands done by the British Association of Dermatologists, and I usually print that off for people because it talks about how to look after your hands, to wear gloves as much as you can so that things aren't coming into contact with the skin, to wash using an emollient rather than a soap. You can use that instead. And for a lot of people, that education and changing the way they do things and avoiding irritants to their skin can be all that's needed for the skin to get better, along with emollients. So emollients are like moisturizers. Somebody's put in the chat about a steroid cream, and definitely a steroid cream can help short term if it's very itchy, but the changing the way you're doing things is much more important than the steroid cream. I do tend to give a steroid cream if it was like the picture that we'd looked at where there were fissures and it was clearly very quite inflamed. The other thing to think about is antibiotics, because quite often with our hands, if we've got irritated skin and cracking skin, it's an entry for infection. So sometimes they need a course of antibiotics as well. And then this is going to be our last patient, number 8, which is a 5-year-old girl, and the mum said that she's had these warts for 3 weeks on her arms, her legs and her neck. It's kind of come in small groups and they're not itchy or troubling her. What do you want to ask? Anything else that might be useful? Is she otherwise well? Yeah, she's absolutely fine. Anything else anyone would want to know, or shall we just have a look at this? Okay.
Someone just typing in the chat, Nikki.
Okay, I shall wait until they've. I think they've just stopped. That's fine.
Yeah.
Okay, so this is what you see when you have a look at these. And how would you describe these if you're going to write down a description of what we're seeing here?
Papular.
Yes, so they're papules, absolutely.
Well defined.
Yeah. Oh, and Gemma's put on the chat a punctum present, and there's something going on in the middle of these, isn't there? They're not like a typical papule where we'd expect it just to be dome shaped on the top. We've got something in the middle, and this is a term, so people are saying vesicles and bulla on the chat, and they're not, they're firm. So if you touch these, they're firm, they don't feel like they've got fluid in them, but they've got that little dimple in the top. And we call that umbilicated. I suppose it looks a bit like an umbilicus. So we'd call these umbilicated papules. Does anyone know what this is?
Molluscum.
Molluscum, yeah. Molluscum contagiosum. Yeah, which is quite common in kids, and quite alarming to have all these strange spots on your skin. What would you do about this if you saw someone with it? Would you give any treatment?
I believe there is nothing to do, but parents get really stressed about it and keep coming back because it takes a long time to clear.
Yeah, it does. Yeah, so ideally do nothing. And for quite a lot of people, they're happy to know what it is. And we've all got the internet at home, so you can write down the name or give them an information leaflet about it. And a lot of people are quite happy, and they will go eventually, but they can take a long time. Yeah, so people have just been putting in the chat, give them advice only, maybe have an emollient if it's itchy. They don't tend to itch, but yeah, there's no harm in using an emollient. It's not going to cause any problems, and it feels like you're doing something to help. And someone said about,
is there a known cause? Sorry.
Is there a known cause? It's a viral cause. I think it's a pox virus. And so it is contagious to other people can catch it, but it's not massively contagious. So Katie has written in the chat not to buy products suggested on the internet. Yeah, and I'm sure there's lots of things that are suggested. They used to traumatize them, so they used to say prick it with they always said prick with an orange stick. I don't know what an orange stick is, but it's some kind of stick. If you traumatize them, they do then sometimes go, but we don't advocate doing that anymore because you can then get scarring, and it's traumatic for a child to be doing anything to these. There is a cream called Moludab, which was promoted for a little while as being a great treatment for molluscum. It's not something that we tend to prescribe, but sometimes patients come and ask about that because they've read about it and know that it's available. What would you do if you had someone with molluscum and they came? Oh, Rebecca's very helpfully, she's told me an orange stick is the thing you use to push back the cuticles on your nails. Thank you, Rebecca. I always wondered what it was. Yeah, so what would you do if the mum came, maybe she'd already had the diagnosis of molluscum, or she just knew that's what it was, but came and said the skin around them is all red and sore looking? What would you think in that case? Anything? Would you give them anything? Okay.
Scratching them a bit, so the emollient or possibly an antihistamine.
Yeah, okay. And someone said in the chat, check for secondary infection. And I think all of those are reasonable. You know, normally they look like the picture where you just see the papules and the rest of the skin's normal. If they go red around it, you could think, have they got infected? Have they been traumatizing them? And someone has said about a low dose topical steroid. I think that they tend to go red around them when they're about to disappear. So quite often the skin goes red around it, and there's like something going on as if it's fighting off that infection. And I think antibiotics, topical or even oral, or a little bit of steroid, well, I probably wouldn't use the steroid cream. I'll tell you in a second, but I do sometimes think you need some antibiotics because it might be an infection, but you can tell the parents that it might be that your body's actually getting rid of it. So it can be a good sign. You have to be a bit careful putting steroid creams near things that are caused by an infection, so like warts or this molluscum, because it can cause it to spread. So if the skin was kind of scaly and red near it. And you might have someone who has molluscum and also has eczema, so needs some steroid cream for their eczema. You have to be quite careful not to kind of rub it over the whole area and cause any spreading of the molluscum. So any questions about any of those patients that we've just talked about, looked at, or things that have just cropped up that you want to ask before we do the last section, which is about topical treatments? I think we might be having a question typed, so I'll just wait for that.
With things like the contact dermatitis, how long would that clear up once you start treatment?
Yeah, good question. And in a sense, it takes quite a while to fully get on top of it with looking after your hands and emollients. And that's why I often do give some short-term steroid at the start, because you're going to get quick results by putting steroid on it. It will feel and look a lot better, but the skin itself isn't healed, and it'll take lots and lots of emollients for weeks and weeks for that to happen. But the patients are quite distressed by the time they come to us, and so a short amount of topical steroid makes a real difference to them, as do antibiotics. And if I see someone who's got really bad contact dermatitis, lots of emollients, a short course, maybe 5 to 7 days of topical steroid, and if there's any suggestion of infection, an antibiotic, and after a week things will look a lot better and they will feel a lot better about it. But it's really going to take weeks and weeks, if not a few months, for the skin to be healed fully. And it will break down quite easily if you come into contact with irritants, and until it's really fully healed, and that will take quite a long time. So in that education about looking after your hands has to be a long-term thing. I just had another question in the chat which says, how long on average does the molluscum last? And I think we don't really know. It always used to be said it can last up to 18 months. I think I've read somewhere that it can last up to 2 years, so it can last a long time. I would say for most kids that have it, it's probably a few months, but it's variable. Any other questions, or shall we move on? Okay, so this is a little section now about prescribing topical treatments. We've talked about various things, emollients, steroids, and things, but this is a little bit more about how we actually choose the ones that we want to prescribe. So we'll start with talking about emollients, and emollients are basically moisturizers, and there are lots of different ones. If you have a look at it in the books, you'll see that there's loads of different emollients that you can prescribe, and how do we choose what's the right one? So this was a bit of a revelation to me when I did my diploma. I wasn't aware of the fact that there were different groups of emollients. So we can either use ointments, and they're the really greasy emollients, and they're very good if the skin's very dry. So they're things like, if you think of kind of what Vaseline is like, those would be the ointments. Creams are less greasy, to get absorbed a bit better into the skin, and they're very good if the skin's weeping. So if you've got infected skin or very acute eczema can weep, you're better to use a cream in that area. And then lotions are the least greasy option, and we don't prescribe them all that much, but they are good in hairy areas. So somebody mentioned about Better Cap, which is a topical steroid lotion, and you can use that on the scalp because it's easier to put a lotion on your scalp than any of the creams or ointments. I thought ointment was just like an old-fashioned word for cream. I didn't know that it was a specific category of things. So I get asked a lot, and patients ask a lot, which is the best emollient? How would you answer that? What do you think? is the best emollient when someone's got something that they need, dry skin, eczema, and you want to prescribe an emollient for them. Which one is best?
The one that works for you.
Yeah, and we have a couple of similar answers in the chat, and absolutely the best emollient is the one the patient likes to use. If you go, oh, well, I've been told that in this condition and the skin, this would be the best emollient, and the patient hates it, it's not going to do any good. So it is one place where it's really important that the patient actually likes what you're giving them. So if we're looking at it from a logical point of view, not just what the patient likes, how would we pick what we're going to prescribe for a patient? Do you want to suggest anything? How would you choose? There's this vast array of things that you can choose from. Okay, so 2 people have said price to a degree. Depends on what type of skin condition, CCG formulary, what the local formula suggests, personal experience of creams. I think, yeah, that's really important as well.
I think ones that have multiple use that you can use as soaps as well as an emollient are quite practical.
Yeah, absolutely. And then someone said the presentation and area affected. I think all of those are important. So I'd thought about how dry the skin is. If your skin's really, really dry like this, you're going to pick an ointment over a cream if you can, because it's just going to work better. Whereabouts on the body you're treating. And I mean, we said that lotions are good if we're talking about hairy areas. If we're talking about the flexures, we're better using cream rather than ointment. Ointments just is too greasy to use in the flexures, and cream works better. I put cost in as well, and that has to be a factor that we think about. And I don't know where anybody else works, but if we try and prescribe things, we'll get a box up saying this would be more cost effective, and it will suggest that you prescribe the one that is cheaper but the same. Did you get the printout of the other handout? Have you had a look at the other handout that I gave you that has a list of emollients down one side and then topical steroids, which we'll come to in a minute? But that's quite handy in terms of, I've just listed various things in there, and that's quite nice grouping them, because if you look like in the one that is just cream, it says creamy, that whole list of creams there are probably things that we're fairly familiar, names to us, but they're all essentially the same. So if somebody is using one of those, let's say Diprobase, and it's not really working, it's not made much difference, then if we change it to another one out of that same group, we're not changing very much. If they've got dry skin and it's not really working, we probably need to go up that ladder to something that is a bit greasier. And it still depends on what the patient likes, but at least having that list in those different sections lets you make a logical choice of where to go next. Up or down, depending on what's happened with the one that they're currently using. And as Mike mentioned, they recommend that you have what's called complete emollient therapy. And that means that you get the cream and you rub it on wherever you need it. You also put something in your bath, so some kind of bath additive that helps to moisturize the skin and counteract that drying effect from the water. And you use it as a soap substitute. So we've said water's drying to the skin, soap even more so. And so you can use an emollient to wash with. And pretty much all the creams that we prescribe as emollients can also be used in the bath and can also be used as a soap substitute. So the manufacturers do make separate products to put in the bath and to use as soap. We're advised not to prescribe those because of cost, really, and the fact that whatever cream you've given them should be fine to use for all 3 purposes. So yeah, any of them can do that. What problems do you think we have with emollients? Why don't they work?
Compliance.
What did you say? Sorry. Is that late?
Compliance, sorry.
Yeah, sorry, I can hear you now. Yeah, compliance. Yeah, that is a big deal. We're asking people to put this cream on several times a day, every day. And, you know, other people have put on the chat as well, poor compliance. And we know that happens. I see patients who'll come and say, I want to talk about my eczema or whatever. And I'll say, well, what are you using? And they'll say, I got some cream from here. And you'll have a look and it was a year ago. And you say, well, how often are you using it? Twice a day, every day? It doesn't last that long. And people don't use them as much as they need to use them because it's a bit of a pain for them to do it. So I think everybody's come up with the same thing, poor compliance. So I think, and that ties in with one of the problems that I put on here, that it's really time consuming for patients to kind of put all this cream on. We've got so many conditions, we can just take a tablet and feel better, but it actually takes quite a lot of time to put the creams on. The patients don't like it. So we give them a prescription for something and they just don't like it. They maybe don't like the feel of it. They don't like the smell of it. Whatever they don't like about it means they're not really going to use it. And so it's probably worth being open with patients when you prescribe an emollient and saying there are loads of different ones. If you don't like this one, tell me, because it's only once they like using it that they will use it, and then you'll get the benefits. I think the other problem that I see sometimes is people prescribe too small a quantity. So someone who's got bad eczema, say, they should be getting through 500 mils in about a week or two if they're putting it on all over. So writing a prescription for kind of 50 mils, 100 mils isn't going to go very far. So it's worth just thinking about what quantity we give. And it also gives a message to a patient. I think if you give them a 500 ml pot of something, you're clearly telling them that you want them to use a lot of that, which is what we want to be encouraging. And yeah, so it's worth just looking when you do a prescription for the size. And I know that can be really difficult. It's like the internet shopping at the moment. And sometimes I end up with a huge packet of something or a tiny one because I'm not too good at estimating how big it's going to be from, I don't look closely enough, I don't think. And then cost as well, and cost for the NHS, because we prescribe lots and lots of emollients, but cost for a patient as well. And lots of people with eczema are better with prepayment things, so they're not paying each time they get a prescription, or costs can be prohibitive to them using it enough. Oh, and then yeah, a couple of interesting things in the chat. And Sue had said patients feel the emollient is less important than using steroid cream. And absolutely, and I think that's really important. When they put the steroid on, things get better pretty quickly. But you need the emollients to heal the skin. Otherwise, you're just sort of superficially getting it better and it will break down again very easily. So that's about all that education things with patients, that the emollients are really, really, really important in the background. The steroid cream is a bit of a quick fix, but more short term than the effect you get from emollients. And Gay has mentioned on here about paraffin-based ointments can make clothes flammable. And there was a big warning that came out about that several years ago, that we should warn people that if they got the ointment on their clothes, it makes them flammable. And I had a patient this year, I think, yeah, earlier this year, who I prescribed a cream to, just, I don't know, like Aquamax is what we told to prescribe. And he had read the whole leaflet, and the leaflet said, warning, make clothes flammable. And he said, I'm a smoker, I can't believe you've given this to me. And I thought, exactly like Gay had said in the chat, that it was just the ointments that were flammable, but that warning is actually on all emollients, which makes it difficult. You can't really think, well, if they're a smoker or they're in danger of setting their clothes on fire, we'll avoid the ointments, because you do get the same warning on all of them now. So any questions about emollients, things that we haven't talked about, things that you would like to know?
What's the regime? Do you put the steroid on, wait 30 minutes, is it, and then the emollient?
Yeah, either way. So they say if you're using emollients and steroids, leave it 30 minutes between the applications, but you can do it whichever way round suits you best. And some people prefer to put the steroid on and then wait and put the emollient on. Probably more people put the emollient on first and then the steroid. And the 30 minutes is just to allow the cream to soak into your skin. Otherwise, you kind of end up just diluting the steroid with the emollient and not getting the full effect from it. Okay, no other questions? So we'll just talk a little bit about topical steroids now. So topical steroids also come as ointment, cream or lotion, which was something I wasn't aware of. I just thought they were the same. So the same kind of decisions apply depending on how dry the thing that you're treating is. Would help you to select whether you are better trying an ointment, a cream or a lotion. And then the more important thing as well is what strength of topical steroid you use. So you're probably aware that topical steroids come in different strengths, and they're on that sheet as well that I printed out. And it's usually worth just kind of being familiar with the name of one steroid in each group. So one mild, moderate, potent, and then the very potent one. I thought this was an interesting table. So it said if you have a mildly potent topical steroid, say like 1% hydrocortisone, which you'll see in the mild section on the sheet, if we give that a strength of 1, which is just a nominal idea, then if we treat them with a moderately potent topical steroid, so something like Umivate, that's between 2 and 25 times as strong. Once we move up to potent steroids, we've got into 100 to 150 times as strong as hydrocortisone, and then the super potent, which is Dermavate, up to 600 times as strong, which I think is quite incredible, sort of how much that ramps up in each of the different categories. And it makes you think, really. So how do you decide what potency you're going to use? We've talked about those 4 different strengths of steroid. What would make you choose one strength over another? Anyone? Area, severity of condition. Yep, so how severe the eczema is or whatever you're treating, what they've used previously, age of the patient, area, yeah, all really good. So again, what site we're going to use it on, and then that's what Joanna put the area. If we're going to be using steroid on a very delicate skin like the face, we would want to use a mild steroid only, really. If we're using it somewhere where the skin's a lot thicker and tougher, like the hands, you need a much stronger steroid. So you've got to think about which area are you treating. Another interesting thing is in those skin flexures, so in the groin, under the breasts, any abdominal skin folds, you absorb the steroid more in skin folds, so you would probably use a weaker steroid in those areas as well. And then Michelle said the severity, so have a look at how severe the condition is and pick off that steroid ladder depending on how severe it is, and then the age of the patient. So in babies, we would rarely use steroid cream, but if we needed to, it would only be a mild one. And a similar thing in the elderly, really. We probably use milder steroids in the elderly as well, but those years in between, we can use something a bit stronger, and that's because in the elderly the skin gets thinner anyway, and they wouldn't tolerate the very strong steroids as well. How much topical steroid should you prescribe? And that's always an issue as well, isn't it? How much do they need? Do you have any idea how you can estimate how much people would need to use, or what size of steroid cream tube you would prescribe. Someone's typing. Yeah, so Zoe's put on the chat, there's a guide in the BLF, which there is, and that's what I've copied at the bottom on that treatment sheet, the little bit in the bottom left corner. That's the guide in the BLF for sort of typical quantities. So that's a good place to start. Have you heard of the fingertip units? Okay, some people have. So what the fingertip unit is if you get your tube of steroid cream and you squeeze it from along the fingertip, like in that picture, that amount of steroid cream will cover 2 hands worth of skin. So if you picture putting your hand on the area that you're treating, that will give you an idea of how many of these you need. And 1 fingertip unit is 0.5 gram of steroid cream. All the steroid cream tubes have nozzles that are basically the same size. So when you squeeze them out, if you do this amount, you get 0.5 gram, and that will treat 2 palms worth. So that's another way that you can sort of think in your head, well, what size of area am I treating, about how many hands worth is that, and making sure that you're giving the appropriate quantity of topical steroid. And how often should you apply a topical steroid? Any suggestions? How often would you use that?
Twice a day?
Yeah, and traditionally it's always been twice a day for steroids, hasn't it? And someone else has said once or twice a day. Check the BNF, once to twice a day. What they found is that we always used to prescribe all topical steroids twice a day, but then they did some studies and found that actually potent topical steroids are as effective used once a day, but obviously your side effects are going to be fewer if you're only using it once a day rather than twice. So I generally, if I'm prescribing hydrocortisone, that would be twice a day. Anything stronger than that, I just do it once a day, and that works just as well, but you minimise the side effects. And talking about side effects, do you know any side effects of using topical steroids?
Can they make the skin more thin?
Did you say can they make the skin more thin?
Thin, yeah, fragile.
Yeah, fragile, absolutely, yeah. So we've got lots of skin thinning on the chat, and yeah, to make the skin thinner, they make it more fragile, and it bruises more easily as well. So that's the reason why in older people we don't tend to use very potent topical steroids. And why in anybody, if they're young and they're using a lot of topical steroid, we need to be talking to them about saying, this is the long-term problem with this. You might find it great at the moment because when you put the topical steroid on, your eczema goes away, and each time it comes back, you put it on again. But we need the education of why we use emollients to fully heal the skin, so we're not using too much topical steroid because of the skin becoming thin with using it. These dilated blood vessels are we call telangiectasia, and you can see those in the skin in people who use topical steroids, and that's a really good for not using them on the face, because when you get these, you can't treat these only with kind of laser or something, and so we have to be a bit cautious about topical steroids on the face with that. Someone has said scarring with long-term use, yeah. And this is a condition which I think is worth mentioning if people are using topical steroids on the face, which I really try to avoid if I absolutely can, because there's a condition called perioral dermatitis where people get lots of spots around their mouth, and that's commonly because they've been using topical steroid on their face, and you can buy it over the counter, so people will go out and buy that and use it. And you can treat the perioral dermatitis with antibiotics and stopping the steroid, but it's better to not get that in the first place. And then Katie has said in the chat about adrenal issues, and she's absolutely right. You do absorb a little bit of steroids. So if you're using lots and lots of steroids, then it can suppress your adrenal response. And I think the side effects and that thought is really important, because if we gave everybody Dermavate all the time, they would think it was fantastic because it will work really quickly, and they'll get what they want of their skin feeling and looking better. But when we look at, if you remember that table where it said Dermavate is 600 times as strong as hydrocortisone, we're building up lots of problems if people are using Dermavate a lot, because they're going to get these side effects much more easily. So we do need to pick a potency of steroid that's correct, because anything that's actually too strong is going to just look like it works brilliantly, but we're storing up problems for the future. So any questions, anything I haven't said about topical steroids that you want to ask about? So Maria asked, can you get perioral from one use? So the perioral dermatitis, it would be unusual to get it just from one use of hydrocortisone. You need to be using it for a while. And I do prescribe hydrocortisone to use on people's faces short term for kind of 5 to 7 days, sometimes when they need that, and that doesn't lead to a problem with the perioral dermatitis. What you tend to see is that someone's bought some hydrocortisone or been given it at a doctor and used it for something which gets better, and then it comes back and they use it again and they've used it quite a while, and then they get these spots, so they put the steroid on that and it does calm them down, but it makes it worse. And by the time they come and see somebody, they've usually got into quite a vicious circle where they're like, I can't stop my steroid because it's all way worse if I stop it, and they have to stop it. So it's quite tricky to tell them you have to stop it, because it will get a little bit worse before it gets better. And antibiotics treat it quite successfully. So it's actually quite a satisfying one to treat if you see anyone with that. And wearing a face mask can affect. I mean, wearing a face mask is affecting the skin on people's faces with getting spots or getting dryness around the mouth, and it's unavoidable really at the moment. We can only just treat what they've got if they have got a rash from a face mask. Any more questions? Okay. So we've kind of gone through those basic principles of how we choose what emollient we're going to have, how we choose what steroid we're going to have. And I've just got a few cases. So this is the treatment side before. We don't need to talk about the general measures and other things. This is just about the prescriptions now. So this is the little girl we had in case 1. And what I want you just to think about is, if you were going to write a prescription for her, and you can look at the handout that I gave you with all the different creams and steroid creams and things on, what might be a sensible prescription to try with her? If we'll say she's tried nothing before, so we're going in, this is the first time she's had any treatment for this, what might be sensible to try?
I certainly use steroid cream, hydrocortisone.
Okay.
Would it be worth, with Fusidin, would it be worth having a combination cream with that, just while it's still looking a little bit infected?
Oh, I'm glad you brought that up. So there is quite a lot of people do prescribe kind of Fusidin H, which is hydrocortisone, and a topical antibiotic Fusidin. What they've found is that using too much Fusidin topically increases the amount of our MRSA on people's skin. So if it looks infected, I think it's fine to use Fusidin short term, but you don't want people to use it all the time. And what sometimes happens is, say they came to see you and you gave them a prescription for Fusidin H and it all got better and they're really happy. And next time it flares up, they just ring up and say, can I have some of that cream I had before? You can get into the place where then they're using Fusidin where they don't need to have Fusidin. Do you see what I mean? So
would it be better to do 2 separate prescriptions then and just use a Fusidin when suggested?
Yeah, so it might be better to say this is a topical antibiotic, we don't use it a lot, but you could use this for the next 5 days or a week, and you need the steroid cream. But then I don't know whether you need to leave much of a gap between the topical steroid and the Fusidin, considering you can have them combined. You can probably put them on at the same time, to be honest. But then you're giving a message for the future of if your steroid eczema flares up and gets a bit itchy, the hydrocortisone will help to settle that itchiness down. If it's looking like it might be infected, maybe it's weepy, it's quite sore, then you might need some more antibiotic, just so that it doesn't become a routine that you always use Fusidin H. If that makes sense? I think that's probably more sensible. But you're absolutely right. So you would prescribe hydrocortisone, and lots of other people have put that in the chat. So Michelle had said she'd do hydrocortisone 0.5%. Would anyone else do 0.5%? Or generally it comes as 0.5% or 1%. I think either of those is fine. And people have said an emollient, but which emollient would you give them? What would you give this little girl? So Rebecca said Diprobase, which I think is a really good place to start. I would probably start as well with one of the creams, so something in that section. Sue says she would give Aveeno. Most CCGs hate Aveeno because it's quite expensive. Patients seem to love it, so it's a reasonable one to prescribe, but the CCG probably wouldn't love that. Diprobase good, Zero cream, which isn't on my list, but is one of those creams as well. So yeah, I think everyone's picking the right kind of emollient. And actually, because it's in the flexures, your knee isn't quite as much as some of the other flexures, but you're better with a cream than an ointment. And hydrocortisone, 0.5% or 1%. I would usually do 1%. I tend to just save the 0.5% for babies, or sometimes faces if I need to use a steroid. So I would probably go for 1% hydrocortisone cream and one of the cream emollients, so something like Diprobase. Our prescribing software asks us to change that to Aquamax, so that's become what I do now. I think that would be appropriate. If the itch isn't troubling her too much, you can start with just the emollient, and you can even give the prescription for steroid and say she might not need it. But I think it does look quite inflamed, and she's probably going to thank you for having a bit of steroid on that to calm it down. So good. And then if we've got this man with his rash, what would you choose for him? Emollient first. Katie says, yeah, I agree. And which emollient would you choose, Katie, or anyone else? Okay, so Sue said double base. Katie says something from the cream section. Nicola says Diprobase. So people are kind of seem to be going for the creams. The double base, which Sue suggested, is slightly greasier than that. It's a little bit higher up that emollient ladder. You see, I think when I look at this picture, and it's difficult just from a picture, I think that skin looks really quite dry to me. So it would be fair enough to use a cream, but I might go higher up, and I might suggest that we even went for an ointment in this person. So maybe the double base is a halfway house between the two. But if the skin's very dry, then I do use an ointment. And I know you find that a lot of people don't like the ointments because they are very greasy. Think of Vaseline and putting that on your skin. Some people love it, a lot of people hate it. And what I've found can be quite useful is to use something less greasy through the day, but they're often happy to put it on a greasier cream at night time. And they get a lot of benefit from that. And I think it's difficult for people getting ready in the morning and having to put all this cream on, which is already a pain. And then if it's all greasy and it sticks to your clothes, it's just not pleasant. So there's good reasons for not prescribing an ointment to use all the time, but you can do a mixture. So if you see very, very dry skin and the patient can't tolerate using an ointment all the time, use a cream or the double base if they can tolerate that in the day, and an ointment overnight. That seems to work really well. And so I think everyone's agreed that they're going to give this man an emollient of whatever kind. How much would you give him? I suppose it depends whether he's got it elsewhere. If his skin was like this in lots of areas of his body, how much would you put on the prescription for him? Yeah, and Zoe says 500. So yeah, 500 grams. Emollients come in big bottles, and we tend to prescribe big bottles. And I think that gives a message to patients as well. If you're giving them a big bottle of cream, you want them to use lots of it. And if they've gone and paid £9 whatever for it, then they want to get quite a lot for that £9. And if they're using it all over, 500 grams won't last them that long. So I always do my prescriptions for 500 grams. I sometimes, if it's kind of hands and things like that, and so you want people to use soap substitutes, I sometimes write 600 grams because then they get a big pot which they can keep at home, and they'll get a 100-gram tube as well, which they could put in their bag and kind of take to work or take out with them for the day, so that they can keep putting cream on through the day. Because actually with emollients, the more often you put them on, the more good they do. So,
Nikki,
yeah.
can I just ask your opinion? I've had a few patients come through that have used oils like coconut oil and various things. Any view on that?
I think it can be really good, and if it suits people, I think it's fine, and it would come in the kind of ointment level of greasiness. And I suppose it's not different to people who buy some branded hand creams, and you'll say, I'm going to prescribe you an emollient for your hands, it's a moisturizer, and they say, I've already got one. When it's just what other things are added to it. And so I suppose what we have with the creams we prescribe is they've been tested in patients with skin disease, and they work, and they shouldn't aggravate the problem. But things like coconut oil is quite a pure oil, and if it's not aggravating them and it's helping with the dry skin, I don't have any problem with people using that.
Thank you.
Oh, and then Tracy just put a question of, can you still use the big pots? I thought you had to use the pump dispensers for infection control. And she's absolutely right that the pump dispensers are much better because we're not sticking our hands into a pot of cream and introducing bacteria and things into the cream. And that's why the pump dispensers are thought to be better. But ointments don't tend to come in pump dispensers. Ointments still tend to come in pots because I think they're just too thick to get out in a pump. And what they advise in terms of infection control, if you're using those pots, is that really you should get the ointment out with a spoon and then use that ointment. And obviously then you wash the spoon so that you're not putting your hands into the pot, so that you're putting something clean into the pot each time. Yeah, good point, Tracy. Thank you. So we're back to Our Lady with her hands. what are we going to write on a prescription for this lady? We've talked about all the hand care advice being really important, so we ignore that bit for now and just what we're going to actually write on her prescription. Anyone? Ointment and steroid preparation. Okay, fine. So Katie thinks an ointment would be a good idea. Sue, epiderm. So yeah, good. Epiderm's always my first choice of ointment. Good.
But wearing gloves at work when you're washing hair.
Is that what, sorry?
But wearing gloves more often.
Yeah. Yeah. So all of that advice about the hands is as important, if not more important, really, than what we give them. Tracy thinks she'll give some hydromol at first. Would that be hydromol ointment, presumably? Because hydromol, the annoying thing with some of these, I think hydromol might be one of them. Epiderm's certainly one of them. They come as an ointment and a cream. So that's why it's important to know that ointments are different to creams, so that when you write the prescription, you can write epiderm ointment if that's what you want, rather than epiderm cream. And Nicola's gone for epiderm ointments as well. And people who've put in that they would give some steroid, what strength of steroid would you be choosing? Which actual steroid cream would you choose for this lady? So if we say our hands are really sore and itchy and cracked, I think it's very reasonable to use a steroid initially. Okay, Katie would give Humavate, moderate. Okay, anyone else? Nicola would give potent, and then a Humavate. So everyone's going for like the moderate or the potent topical steroids. And I think either of those is fine. I tend to use Betnovate on people's hands because you've got pretty thick, tough skin on the hands. And maybe you'll use it just for 5 days or 7 days. But Humavate's a reasonable one to choose as well. Hydrocortisone is probably a bit mild for hands, so I'm glad you sort of went for something a little bit higher than that. And I don't really prescribe Dermavate for anybody other than for lichen sclerosis, which is a separate condition. So I think either Humavate or Betnovate would be the right steroid to use if you're thinking of using that. And then this lady who's got this redness, some kind of dermatitis on her eyelid and round her eye. And it's always tricky when it's someone's face, but what would you give her to try? Okay, so what have we got here? Very low dose steroid. So Katie. Someone else is just typing. Emollient cream with a mild steroid. So which emollient are we going to, Sue had put on there an emollient cream, which one are you going to pick for around the eyes? Cetraben, yeah, which is one of the creams. That would be fine. Aveeno, lots of people like Aveeno. I never choose to use Aveeno first line because I think I'll get in trouble for doing that. I only use it if other things are failing, but patients do really like it, so that's a reasonable thing to do.
Nikki, would there be any argument if someone said, but I use a moisturiser regularly anyway on my face, do I just use that more, like a oil of Olay or something like that? Would that have a similar effect?
Yeah, possibly. I mean, I wouldn't discourage people from using things that they normally use. I think the issue once your skin's inflamed and irritated is things that you normally use might irritate that skin where they wouldn't when your skin's healthy. So it's probably worth giving them something else to use as well. And probably something, if you prescribe something, any of the emollients, to put that on first and then to put their normal face creams on top. But I think the commercial things that you buy that people use tend to have a lot of perfumes and other chemicals in them that are not particularly good and might inflame the skin more. So I would try to encourage them to use a prescribed one.
Yeah, thank you.
Actually, another thing to say about ointments and creams is ointments have fewer ingredients in them. So people who are quite allergic to things are often better with ointments and creams because there's less chance of reacting to them because they don't have as many ingredients. You have to put more stuff in to make that paraffin into a cream, and people can develop contact allergies to the cream that you're treating them with, so ointments can be a better choice. So Cara says the hospital like Aveeno and see lots of it. CCG doesn't, but it is a good cream. So yeah, I think any emollient around the eye is fine. And then I think people had talked about steroid, maybe a low dose hydrocortisone cream was on the list. And I would do exactly the same. I would give them an emollient. And for some reason, I do tend to use ointments when I'm prescribing for eyelid conditions. And I don't know whether that's just because when I've seen them, it's looked really, really dry, or whether there's any other reason why that's what I tend to select. But if they can tolerate the idea of putting an ointment on, that's what I tend to do. And I would use I'll say that in a second. I would use either 0.5% or 1% hydrocortisone if it was really inflamed and really itchy and troubling, or if they tried the emollient on its own and it wasn't better. But I'd only use it for 3 to 5 days, just very short term, because the skin's very thin. Using steroids long term around the eyes can cause cataracts as well. So it's okay to use it very short term, as I say, 3 to 5 days. And Rebecca's just put another point on the chat. She said, we're told to ask patients to buy their own emollients when they're available over the counter. And yeah, we are. And that it would be ideal. And I think the NHS probably spends a fortune on emollients and all these other things that we can buy over the counter. When you tell people to buy them over the counter, they're really expensive. And the problem is, this is a dilemma that I have, because we think, well, yeah, you can buy this. You shouldn't need to take my time and all the time generating a prescription and all the costs when you can buy it. But, you know, a pot of Diprobase will cost £12 or something. And even if someone's paying for a prescription is cheaper than that. And my concern is that if we're telling people we don't do prescriptions for this, you have to buy it, they won't, and then they'll just be steroid dependent because they're not using emollients enough. So I have that dilemma where I think we shouldn't be prescribing all these emollients, particularly for elderly people who haven't got a skin condition as such. Everybody's skin gets dry as they get older. And I can remember a very well-off lady who said to me, oh, I need my prescription for whatever emollient she was getting. And she said, it's great. I used to buy really expensive face cream from wherever, and this is just as good and I get it free on prescription. And I totally thought, this isn't really what the NHS is about. But if we don't prescribe it at all in people who need emollients, then I think we're going to end up prescribing more steroid because they're not moisturising their skin. Right, there's a little bit of chat going on about patients buying their own. And Michelle says, I thought the advice had changed and we can use for long-term conditions, but buy over the counter for short-term conditions. Zoe says some people use 3 a month and it's very costly if they use it all over long term. Yeah, I mean, if they were cheaper to buy, then I think people would be more prepared to buy them. But I think, particularly for the things like we've just looked at, people with eczema and so on, that we ought to be doing prescriptions for them, really, to make sure that they use them. I guess we could. It's easy just to say they are available to buy. So if you need some more, you could buy it and leave it up to people whether they will do that or not. This eczema, the eczema around the eye is the last patient slide that I've put in today, and it was interesting because I saw this slide for another talk that I was doing. And I think it's interesting just to talk about what we use on faces and near eyes. But this was actually someone had a reaction to the nail varnish, and that's why the fingers are in the picture as well. And then having seen this slide a few weeks later, I saw a girl at work who'd had really bad eyelid eczema, and she'd seen various people, and she came to see me, and I gave her a prescription for whatever, and I said, oh, it's really interesting. She had really nice nails, like that lady. And I said, I saw this picture very like that, and they were reacting to their nail varnish. And she said, oh my God, I got these false nails put on, and actually that's when it started. And I said, oh, you know, it could be that. And she said, I'm literally on my way from here to go and get them taken off and a new set put on. I think maybe I'll just get them taken off because might have caused it. I've never seen them again, so I don't know what the outcome was, but it was interesting that I'd just seen that, and then I saw that patient. And the thing that they say about rashes on the face is that we all touch our face a lot. And so actually quite a lot of the rashes we get on our face do come from things that we put there ourselves by touching our faces. So I don't have any more things that I was going to tell you about. And any questions about anything we've talked about today, or about anything I haven't talked about that you would have liked to, or any questions at all? Kate has just put on the chat a link to the eczema.org, which has information about prescribing emollients on prescription. So yeah, I might have a look at that. Thank you. Yeah, the eczema.org is a good website for people who've got eczema. It's a good place to direct people to, and on it there are eczema treatment plan things. So you give to patients like we do with asthma when they're supposed to take away a personalised asthma action plan. There's the same things for eczema where you write down the name of the emollients and the names of the steroids and when to start them.
Nikki?
Yeah.
I just had a patient earlier in the week that had, I have to be careful how I say this, cradle cap.
Yeah.
I've been using Dentanox on it, but it was becoming quite stubborn and red. I was reluctant to put anything on it, being a very young baby's head, and said you just need to keep persevering with that, and it will be red just by the nature of what you're doing to it. Is there anything that hastens that, or is it just really take your time and it will clear?
Yeah, probably just take your time. I mean, there are different shampoos you can use, so you could try something different if what they're using isn't working. And I guess it depends if it's distressing the baby or not. It's often that the mum doesn't like the look of it, rather than that it's causing any problems for the baby.
Yeah.
I mean, if it was really inflamed and sore looking, you could put a little bit of topical steroid on short term and see if that helps. But really, it tends to be emollients and shampoos if they've got, got hair or whatever, that helps to settle that down.
Lovely, thank you.
All right, I'm just having a look at these. Would you mind me asking what creams you use for diabetic foot care? Oh, I don't do a lot of diabetic foot care. So Tracy asked that. What kind of thing were you meaning? What emollients would I recommend? Can you? Well, I mean, I would tend to just use any emollients. And Katie said high urea content. So actually, yeah, on that sheet I gave you, I didn't say that. If you look in the cream section, they're in different colours. They're not on my sheet because I only had a black and white printer, so I can't remember what colours they are. But the balneum and calmurid are in a different colour, and that's because they contain urea. And so if we're changing to a different cream, so if we're not looking for something greasier, if we're looking for something that's the same but slightly different, then it's worth picking one in a different colour on that list. And the E45 Itch Relief had something different into all the others, which I think was Laura Macragol's, but I might have remembered that wrong. But that's a logical choice to pick one of those in a different colour. So Katie says you should have a high urea content for diabetic foot care. So on that basis, the balneum or calmurid would be good. If you're talking about the kind of feet where the skin's really thick on the heel, which we see a lot, and the pressure points, then the urea containing creams are supposed to be the best ones to break that down. So balneum I would use a lot. And I actually had one man who had the thickest, incredible skin on the sole of his feet. I wish I had a photo of it. It was incredible. And I looked up, or I didn't say earlier, Primary Care Dermatology Society have a really, really useful website. So it is worth having a look on there. And I looked on there about treatment, and they said you can put the cream on, so like the balneum or calmurid, and wrap it up in cling film overnight, which he did, and he got better actually in the end, but it took a long time. But yeah, that was interesting. Any other questions? I just thought I'd put up the learning outcomes again, because hopefully you can think, hopefully we've covered those: how to assess a patient, how to describe a skin problem, how to recognise some common problems, and have some logic to prescribing topical treatments. Right, I think there's just another question on the chat. What are your thoughts about using calcineurin inhibitors if the steroid isn't working? I don't tend to use it much myself, and I think the place for the calcineurin inhibitors is you use them not because the steroid's not working, but because they're using lots of steroid to try to reduce the amount of steroid use. So I think that's the place for them really, but I have to say it's not something that I use a lot. But I'm just having a quick look if there are any more questions.
Hi, it's Ruth here. I've noticed that a couple of people are asking whether we're planning any future sessions on skin lesions. It's certainly something we'll look into, and any courses that we do organise are advertised on our social media, and also emails will be sent out to the practice managers. So keep an eye on our social media and check with your practice managers for further details, please.
Thanks, Ruth. Thank you. And this is going to be my last thing. Obviously, you can ask questions if you want, but just have a think about one thing that you've learned today that you didn't know at 9 o'clock this morning. And if you want to share that, that would be really nice. So you can speak, or you can put something in the chat, but that would be good. So while you think about that, this is all on the handout anyway. Primary Care Dermatology Society website, I said, is really, really good. DermNet is also really good. Those are the two that I tend to use quite a lot. Patient leaflets you can get from various places, but patient.co.uk have quite useful, easy to read ones, and the British Association of Dermatology. So then it feels old fashioned now to say a book, but that's a book that I think is quite good. And it has kind of flow charts to guide you through what diagnosis you might have. So let's see what we've got on here. Cream for flexors. Yeah, good. Incremental potency of steroids. Yeah, I hope that will be useful. Just learn one of the names from each section. I think with the other thing to say with steroid creams is not to prescribe them generically, because we all kind of understand Betnovate and know it's a potent steroid, and Humavate and know it's moderately potent. Humavate generically is called clobetasone, and Dermavate generically is called clobetasol, and it's very easy to get confused between the two of them. So I don't tend to prescribe them generically. I stick to the brand names. No treatment for 2 weeks before skin scrapings. Yeah. Okay, I'm glad you like that degree of increase in potency between the different steroids, because I thought that was really interesting when I saw that, and I was quite shocked, to be honest, at quite how much they went up in strength. Fustin increasing MRSA on the skin. And Tracy, who said that she learned to listen to patients' experiences with the different creams and not just go with the creams we want to use. Yeah, I think that's really important. That's good. Skin fold absorbs more. That's worth thinking about if you're prescribing topical steroid. And Cara is just saying, does everyone have the dermatology book from the hospital? Yeah, I got sent one of those a few months ago. So they definitely got sent out to practices, I presume, but I don't know who received those. And so you said a more precise description of skin conditions. Oh, and Cara says her dermatology thing is old but good. The one I got, I think it was in the summer, it was certainly a few months ago, was a new version of it. It's been updated. And it just appeared in my tray at work, so presumably they just got sent round. So it might be worth inquiring if you can get a copy of that, because it is good. I'll email Ruth the handouts. I said all the things that we've had on today, I've put them all on handouts, and she can email those out to you so you can have another look over things if you want to.
No problem, I'll do that. And also I'll be sending out a feedback form. So if you could complete that and return with feedback from the session, that would be great. Thank you.
Yeah, actually, I quite like some feedback, because I've not done this on technology before, only face-to-face, and it would be nice to have some feedback about what works and what doesn't work. That would be really helpful. So thank you for joining in, and all those who contributed. That's really lovely. And yeah, I hope you go and make some good diagnoses and feel a bit more confident about doing that.
Brilliant, and thank you very much from our side, Nikki, for providing such a comprehensive teaching session. It's certainly been very informative. Even though I'm a non-clinical, I've enjoyed it myself.
Thank you. Well, that's good. Yeah, so thank you. Okay, thank you.
Right. Anything more to add, Nikki?
No. No.
Okay.
If there's no questions, then that's fine.
Yeah.
And
lovely. Well, thank you very much for your time.
Yeah, I'll send you that email now when I get off this, and you can just pass that on. That'd be really good.
I will do. I'll send that out together with the feedback form. Thank you very much for coming, everyone. I hope you've enjoyed it. And yeah, do keep an eye on our social media, Facebook and Twitter, for details of further training sessions.
Was that okay, Ruth?
That was great, Nikki. Thank you very much. Yeah, technology worked well, and I think it was a really good session. The feedback sounds like it's very positive, and hopefully,
made nice comments, didn't they?
Yeah. I thought it was really useful, and the level of engagement was certainly very high in the chat, and also people unmuting themselves. There's no shyness. So yeah, I thought it went very, very well.
Yeah, I think there were probably about 8 people that did, you know, interact well. Lots of them didn't, but I didn't want to pick on people to get them to interact, because I think once you sit there and you're just terrified, you can't even listen, can you? So at the beginning I was like, oh, is anyone going to say anything? But no, I think it did really well.
Yeah, I think particularly with online sessions, what we've seen is that it takes people a while to warm up, and initially people will be very hesitant to say anything, and then as the session goes on, they lose their inhibitions and are happier to speak.
Yeah, no, it was nice. It was good. Thank you for your help as well today.
Thanks very much, and do get your invoice sent over to me, and I'll forward it to Sarah, who handles the invoices for us.
Yeah, is it Sarah Parkin?
It is, yes. Of course,
she's my practice
Sarah.
manager, so yeah.
If you could keep me CC'd in there as well, that'd be great. Yeah,
and if you did want to do anything about skin lesions, I'll be happy to do that.
Brilliant, lovely, thank you. Yeah, we've got a meeting tomorrow actually with Hannah, one of our lead nurses, to discuss WDF, and I believe we do have some funds remaining for the year, so we'll certainly discuss that tomorrow and let you know.
Yeah, okay. But yeah, it doesn't matter. It's just, I have been doing this full day teaching for the last few years, and that was kind of most of my morning stuff, and my afternoons about skin lesions. So it's kind of something that I've done before as part of the whole day.
Yeah, that certainly sounds a good option then. Yeah, thank you for the offer.
Okay, thank you. I'll go now then. Bye.
It was nice to meet you, and thanks again for your time this morning. Thank you. Bye.
Bye-bye.